जब वहां का बोलेगा ना सुनो राशन सर ये भी होना चाहिए।
देखो भाई चेयर बड़ा और दिख रहा है, उसको हटा देना।
एक बार मुझे जूम करना,
दिख रहा है
सर को जूम करना।
थोड़ा सा इधर सेंटर करो मुझे, नहीं थोड़ा इधर करो, थोड़ा इधर।
नाम की वजह से
हाँ ये परफेक्ट है। दिस इज आई थिंक दोनों लोगो आ रहा है, इतना ही जूम करना।
10 लोग तो आ गए कम से कम।
नीचे भी आ रहा है ना, 55th स्थापना दिवस भी आ रहा है।
उनका नाम आएगा।
हाँ इससे छोटा नहीं करना, इससे बड़ा नहीं करना। डन हो गया
ये पक्का लग।
अच्छा या नाम इधर आएगा।
एक नाम की स्लाइड डलवा दे मैम, डलवा दे।
कितने जन तुम लोग बचेगा तो बाद में देखें। प्रॉमिस द विल तो आएंगे, बेल भी तो उनकी कराओगे तो हम देंगे। सर के ऑफिस से मिलेगा सबको। इफ यू आर देयर फॉर 3 days तो कैसे समझाओ ना, डोंट से नो, नेवर से नो। तो तुम बोला मैंने कहा सर ने बना करके बात। नाम नहीं आ रहा है। अच्छा थोड़ा ऊपर करो। परफेक्ट परफेक्ट। नहीं नहीं और जूम आउट, जूम आउट, जूम आउट। या ये ठीक, वहां पे दिखाओ।
A very good evening, speakers, and welcome to the virtual
Good morning.
class. Good evening, Dr. Roberto. How are you?
Very good. Thank you.
Okay, Dr. Roberto, I see you are the first speaker for the session.
Yes.
Would you like
Yes.
to share your screen and check the presentation once?
Yes, I will do that.
All right. Dr. Jod, Professor Jod Mehta. Good evening. Welcome. Namaste.
Hi, namaste.
So after Dr. Roberto checks his PPT,
Yeah,
we will have you to share your screen and you can check your PPT
Sure.
once. All right.
okay, great. Hi, Roberto.
Hi,
Okay.
good, John. Good morning.
Morning.
Or
How are
good
you?
evening. Good evening.
We exactly have 6 minutes from Indian time to begin with this. So let's quickly go through our presentation check.
Okay.
Post Dr. Jod Mehta, we have Dr.
Hello. Hi, John. How are you?
Okay, good, thanks.
That's-
Good,
that's-
namaste.
that's
hi,
me,
hi. I
Namrata.
can see you. I can see you.
You
can
Okay,
see.
I can see you now.
Hi,
Yeah,
Roberto.
Hi, Namrata. Thank you. You look wonderful.
Thank you. So we are here. इसको zoom करना जरा. Zoom out करो. Zoom out करो. So we all are here.
Okay.
Okay.
Good evening, Dr. Namrata. Namaste.
Hi. Sir, आप कुछ बोलो. We have our chief Professor J.S. Tityal sir here.
Okay.
Very good evening and good morning to all of you. And
Good morning. Good morning, Dr. Didio.
Yeah. Hi.
Hi, Dr. Pereira.
Hi there. Hi,
Hi.
God.
Hey, Kishore.
Very nice to see, and thank you for joining us today.
Pleasure.
You'll come here.
Yeah, Dr. Roberto, would you like to share the screen once?
Of course.
Let's do the technical check quickly.
I think the super dry t-shirts are a big hit there. Singapore also, is it? Jodh?
you've got very good eyesight.
Yeah, 2020. So why do they call them super dry?
It's Japanese, right? It's Japanese. It's actually English, right? But they try to use all the Japanese symbols on it.
Yeah, that means the people with dry eyes should not be using it. I'm just.
That's
food
right.
for thought.
I thought it's an appropriate thing for a corneal for a symposium. You see, for
Epiphora.
dry eyes.
Patients with epiphora can try it out. It might just reduce the tearing from the eyes.
Absolutely.
Dr. Roberto,
Yes,
everything okay from your end?
it looks very good. Yes.
Are you not able to share your screen?
Oh, I'm sorry. Oh, my fault.
We're waiting for you to do the technical check. sir.
Yes. I understand. Sorry.
Dr. Suchi, namaste, welcome.
Hi.
Hello, Dr. Chi. How are you?
Hi,
Sir
Namrata.
is also here. Dr. Tityal sir.
So, ladies and gentlemen, we just have 6 minutes to go before we start with this lovely event. Yes. Dr. Roberto, you can stop sharing. We can see. Thank you so much.
We
Okay.
have 6 minutes. I think we all
Professor Mehta, would you like to share your screen and check?
Sure. Yep.
Yes.
Welcome, Chi. You're looking forward to your subluxated classes? Are you talking
Thank
about
you.
that only? Pick up the dropped ones, right? Take them
No,
along.
no. This is pediatric, not so bad.
All right, that's good. That's pediatric is fun. Yeah. See, pediatric makes more sense because these kids have to live for another 80, 90 years, right? If you do a surgery in, say, 60-year-old, that man will have, say, 30, 40 years at the maximum if he touches 100. So
Yeah.
here you actually mean it, actually. That's a great job.
Yeah, thanks.
Okay.
Yeah, Professor Mehta, yes. Is
Okay.
there any video which you're going to play?
Yeah, I was going to play the video. Actually, it's a video. I recorded it
Yeah.
already.
Yeah, can you play the video? And I hope you have selected the audio. Yeah, you need to increase the volume
Okay. Yeah. No problem. I
from
can
the
do that.
computer as well.
Sure. I'll do that. Okay. No problem. I'll do it.
Technical team, can we enhance this audio, please?
I can do it here from. I'll do it from here. Hang on.
So while you share the screen, you have an option.
Yeah, I've done it. I've done it. Here you go. Try it now.
molecular changes following refractive surgery. These are my financial disclosures. They don't really pertain to
Okay, technical team, can we make it a little louder, please?
spinal and LASIK are two of the most commonly
Yes,
used.
sir. Professor Mehta, you can stop sharing now.
Okay,
Thank you so
thank you.
much.
Thank you.
Yeah. Dr. Pereira, would you like to do the same exercise, please?
Yes, please. Here's share screen.
Yes.
Can I just check that you'll be playing my video and that you have it?
Yes, Dr. Chi, once we are done with Dr. Pereira, we will
Okay.
take a technical check with you as well.
But you should have my video.
Yes, Dr. Pereira, we can see your screen. You can stop sharing it now. Thank you.
Okay, there's no video.
There's no video. All right.
Boo, boo.
Technical team, we have Dr. Chi. She must have given her video. Can we play it once, please?
Hey man, I've sent my video as well, so you could actually play it from your side instead of me playing it. I mean, I don't mind. But
Yeah, no problem, sir. We'll just take the note of that.
yeah, it was easier.
All right, so I think we are done with the technical check. And we exactly have 2 more minutes before we start with this event. So I would like to, I'll begin with this event. So ladies and gentlemen, a very good evening, and people from abroad, a very good morning to you. Namaste. Welcome everybody to the 55th RPC Annual Foundation Day celebrations, the RPC Ophthalmic Carnival. I am your team manager, your time manager, Himay Lakhani from Hall A. We'll be having 15 minutes for each speaker to do the presentation. Post that, we'll be having the question answer session. I would like to invite our chairpersons and introduce our chairpersons. Dr. Jeevan S. Tatyal. Warm welcome to you, Dr. Jeevan. Dr. Radhika Tandon. Welcome, Dr. Radhika Tandon. Dr. Sudarshan Kokar. We will also like to welcome our chairperson, Dr. Namrata Sharma. Good evening, ma'am. I would like to invite Dr. Tushar Agarwal. These are our chairpersons. Namaste, chairpersons, and a warm welcome to you. To moderate this session, we have Dr. Tanuj Dada, our moderator, Dr. Tanuj Dada. Good evening, sir, and a warm welcome. Our panelist for this session is Dr. M. Vanathi, Dr. Rajesh Sinha, Dr. Nupur Gupta, Dr. Prafula Maharana, Dr. Nevi Lomi, Dr. Manpreet Kaur, and Dr. Sridevi Nair. So ladies and gentlemen, once again, a warm welcome to this lovely conference, the RPC Ophthalmic Carnival. Now I would like to hand over the virtual dais to our chairpersons and our moderator. Dr. Tanuj Dada, the dais, virtual dais is all yours. And we have Dr. Jeevan Tatyal as well. The dais is all yours. Namaste. Thank you.
Good evening, everyone. A very warm welcome to the 55th Annual Foundation Day celebrations of Dr. Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. We are going to start the scientific program, and joining us on the dais is Professor Jeevan S. Tatyal, Chief of the RP Center, Professor Radhika Tandon, Professor Sudarshan Kokar, and Professor Namrata Sharma. So this is the first session, the international session, and I would request Chief RP Center, Professor Jeevan S. Tatyal, to inaugurate the session.
Thank you. Son. Thank you, Professor Tanuj Dada. Indeed, it's a very, very important day for RP Center, which was incepted 55 years back. And it's been the pillar of eye health care in this country for so many years. It's Apex Institute of India to deliver the eye health services to entire country. In fact, RP Center has been the pioneer in starting the first blindness program of the world, in fact. And it has really created the importance of three-tier system in eye healthcare. Today is our privilege to have scientific activities going on. And to begin with, what would be better than having a international session with our friends joining from a different parts of the world with their experience. Their contribution to this field has been so immense. We are absolutely delighted that they could join us today. All my friends are most welcome. They are going to join us online, though it's so difficult to be physically traveling to different parts of the world. But I'm pretty sure next year in the same program, you all will be physically with us. You have been to RP Center, especially Roberto has been in RP Center with us for so many times. I'm awaiting other people to join us in RP Center, especially my dear colleague and friend, Professor Chi. You must come to RP Center once before. And let's begin the session. I'll request the moderator to start the session. Thank you again.
Thank you, sir. I would now like to request Professor Radhika Tandon to introduce our first international speaker.
Am I audible?
Yeah.
Thank you, Tanuj. So, good evening, everyone here. It's quite late, I suppose, in Singapore and quite early in the morning in America. It's a present privilege of mine to be given the opportunity to introduce Professor Roberto Pineda. He actually requires no introduction because he's a world-acclaimed and renowned corneal surgeon. But it's nice to go over all the achievements in front of everyone. So Dr. Roberto Pineda completed his residency in ophthalmology, followed by a clinical fellowship in cornea, external disease, and refractive surgery from none other than the most prestigious and most sought after position at the Massachusetts Eye and Ear Infirmary, Harvard Medical School. And presently, he's working as an associate professor of ophthalmology at Harvard Medical School and is also the Thomas Y. and Clara W. Butler Chair in Ophthalmology and assistant scientist at the same revered institution. He was, in fact, the first faculty member at this institute to utilize clear corneal incisions techniques, topical intracameral anesthesia, and limbal relaxing incisions during cataract surgery, and brought new techniques and technology, including conductive keratoplasty, intacts with intralace for keratoconus, and all the new corneal transplantation techniques such as DLEC, DMEC, DSEC, DWEC, and DALC. Dr. Pineda has been involved in numerous international programs and in his altruistic role has also helped with the Lifeline Express in China, as well as his research with the International Boston Keratoprosthesis for the Needy in Ethiopia and Sudan. He sits on the Alcon Chinese Advisory Panel and regularly participates in Sight Life Surgical Skill Transfer Program for corneal transplantation world over. And we've had the opportunity of him interacting with our residents and coming to personally help our faculty as well with the various programs at the RP Center. So without further ado, we'd like to request Dr. Pineda to present his talk, which is much awaited. Thank you so much.
Thank you very much, Dr. Radhika Tandon. It's really, it's quite a pleasure to be here. And I'm sorry, here we go. And just thank the chairperson and organizing committee for inviting me to today's session. It's an honor to be presenting the first lecture in the session. What's new in ophthalmology. I'm going to be talking about surgical approaches to corneal neurotization this morning. These are my financial disclosures, which are not relevant to today's discussion. So we know that corneal sensation is important and critical in maintaining epithelial integrity and limbal stem cell function. And when one experiences reduced corneal sensation, this renders the corneal surface prone to injury and decreased reflex tearing. This results in poor healing secondary to corneal sensory denervation, resulting in epithelial defects, ulceration, and potentially perforation if not properly treated. Neurotrophic keratitis, or maybe more importantly, keratopathy, is a degenerative disease characterized by reduction or absence in corneal sensitivity. And in particular, neurotrophic keratopathy occurs when corneal innervation is impaired by the trigeminal nerve. Now, the epidemiology of neurotrophic keratopathy is not well known or described, but it's estimated with a prevalence of about less than 50 per 100,000 individuals. Any ocular systemic condition altering corneal innervation can result in neurotrophic keratopathy, affecting the cornea to the pontine trigeminal nucleus. The most common ocular conditions we see are herpetic keratitis, whether it's soft or simplex, but other ocular surgeries or chemical or physical burns or contact lens abuse can result in neurotrophic keratopathy. Non-ocular conditions such as basal skull tumor resections or trigeminal neuralgia surgery or intracranial masses such as acoustic neuroma or cholesteatoma can result in neurotrophic keratopathy. The aim in managing patients with corneal healing, with neurotrophic keratopathy really depends on the stage of neurotrophic keratopathy, which is classified by the Mackey classification. I'm going to pass over this in the sake of time, but basically the bottom line is that really no therapy, maybe with the exception of synergimin, which is oxervate or recombinant nerve human growth factor, can provide any kind of permanent cure for this condition. I want to talk a little bit about the nerve transfer concept. This is where this involves the use of a healthy but less kind of valuable donor nerve or its proximal stump to provide important sensory or motor innervation. And this is actually a very well-established modality in sensory impairment of the hand and foot, motor impairment for vocal cords and facial nerve, as well as mixed sensory and motor impairment. And likewise, corneal neurotization can reverse neurotrophic keratopathy, just as regional motor nerves can be transferred to restore facial movement. Regional sensory nerves can be transferred to restore corneal sensation. And corneal neurotization really involves a use of the common sensory donor nerve sites, such as the supraorbital, supratrochlear, infraorbital, and great auricular nerves. And this can be done either by direct or indirect nerve transfer. Indirect meaning via a nerve graft, either auto or allograft, using either side to side or side to end anastomosis. So the modern corneal neurotization, was first described in 2009 by Terces. Here in this particular paper, they use the contralateral, supraorbital, and supratrochlear nerves. They basically were able to show improvement in corneal sensation, visual acuity, and overall corneal health. And although this was a very successful technique, it did require a large bicoronal incision, as shown here. It denervated the contralateral forehead and scalp. It really is not applicable for bilateral palsies, and it was technically very challenging to dissect the nerves over such long distances. Here's just a photo from their paper showing the innervation from the contralateral, supraorbital, and supratrochlear nerve to the other eye. And you can see the branches and fascicles of the nerve here. And you can see in this photo the corneal nerves being placed alongside or parallel to, tangential to the limbus. Here's a photo from one of their initial papers, basically showing resolution of a corneal scar after direct neurotization of the contralateral, supraorbital, and supratrochlear nerves. Elbaz in 2014 published his kind of more refined technique of this using a sural nerve interpositional graft, which was employed between the brow region and the cornea to avoid this large bicoronal incision. And the sural nerve, just a little anatomy lesson here. This is actually a purely sensory nerve. Its removal just results in a small numb patch over the anterolateral ankle and really doesn't interfere with mobility. The sural nerve is the preferred choice because it has a large number of fascicles and the length of the nerve harvested, and it has a low donor site morbidity. This is from one of our patients. You can see us harvesting the sural nerve here. And this is from their paper, again, showing improvement in corneal scarring after corneal neurotization. And another paper from their group showing improvement in corneal sensation. You can see it takes about 3 months or more to start to really appreciate the improved innervation on the corneal surfaces. Confocal, in vivo confocal microscopy has shown improvement in nerve density in these patients. And you can see in this paper here in the far right, kind of the preoperative confocal microscopy and postoperative in vivo confocal microscopy with increased nerve density. Other studies have shown this as well, showing improvement as early as 3 months with corneal nerve fiber density increasing over 1 year, which has been confirmed both by immunostaining and transmission electron microscopy. There are other approaches using the supraorbital and supratrochlear nerves. And these are just 2 case reports showing the different approaches that can be used in this technique. And this is, we can also use the infraorbital nerve if it's on the ipsilateral side here, using the second trigeminal branch for neurotization. You can use also the ipsilateral supratrochlear nerve, as is described in this Taiwanese paper, looking at corneal neurotization for herpes simplex keratitis-induced corneal, neurotrophic keratopathy. Animal models have been already described to help study the effects of corneal neurotization. And a recent review looking at the overall, looking at corneal neurotization, which included 54 eyes using different techniques, has basically shown improvement in visual acuity here in this paper, essentially improving from 2400 to 2100, and also significant improvement with Cochet-Bonnet aesthesiometer from a little over 2 millimeters to more than 40 millimeters. And the median time to maximum sensation was around 8 months. Other options, other than the supratrochlear and supraorbital nerve, include the great auricular nerve, which is the nerve that we've been working with here. The advantages of this technique, it has more axons, it's an ipsilateral sensation, and again has minimal donor site and avoids a facial incision. The great auricular nerve originates from the cervical plexus. It's composed of spinal branches of C2 and C3, and basically provides sensory innervation for the skin over the parotid and mastoid process, as well as the outer ear, and is currently commonly used in facial reanimation for an interpositional graft. In our technique, we use what's called a sub-S-mass flap, which is basically elevated over the same side of the patient. And again, to isolate the great auricular nerve here, as shown in this photo. And then basically these branches are distally transected and transposed toward the lower lid over the parodomesenteric fascia. We then basically harvest the sural nerve via endoscopic approach. And then to avoid a potential axon loss along the side branches, use only the medial sural cutaneous component from the tibial nerve. As far as the eye, which is a little more recognizable, we use 180-degree inferior fornix-based conjunctival peritomy. We make scleral tunnels after we've lifted up the conjunctiva, as you can see in the lower limit. Basically then pass the nerve graft through this sub-S-mass plane, which I described earlier, into the lower fornix, and then do a fascicular dissection, which you can see below here, and then place those fascicles bluntly into the scleral tunnels that have been created, and then close the flap with fibrin glue around the edge here. And then the tarsorrhaphy is typically placed, and then we basically connect the sural nerve to the great auricular nerve through an end-to-end coaptation, which isn't shown here. I'd like to show the video here. This is just a very short video of the procedure. This is it's about a less than 3 millimeter incision. Here we're isolating the great auricular nerve. And then we go harvest the sural nerve. This is not me. I don't do this portion, although I've dabbled a little bit, but I don't see myself doing this. I rely on my ENT colleagues to do that. Here, we're doing that inferior fornix base peritomy. This is the S-mass. We're pulling the sural nerve through this space here, which is the nerve that you're seeing pulled through at this point. And then once we bring the sural nerve onto the surface of the eye, we basically separate out the fascicles here, and there's anywhere from 3 to 5 fascicles in this nerve. And you can see we're making the scleral tunnels here and placing them into the tunnels and using the fibrin glue to bring down the conjunctiva. And you can see the ends of the nerves here. We perform a tarsorrhaphy, and this is a coaptation of the sural nerve to the great auricular nerve. And I was impressed to see them using fibrin glue here in this process as well. And that's essentially the procedure. You can see this is pre-op for this patient, and then post-op 5 months. You can see the ends of the nerves here, and 7 months out, and you can see the disappearance of the scar as well. So corneal neurotization has really become a hot topic. You can see in December of 2019, there were 79 articles on PubMed. That's grown to 126 by March of 2022. And you can see the grid below here showing the number of articles published in this field. As I mentioned before, the Cochet-Bonnet anesthesiometry is not a device I'd used heavily prior to this, but I use it very regularly now in clinic. These are just some cases showing improvement in corneal sensation after a year or more, with improvement in vision in these 3 of our cases. And again, we can usually appreciate it. One funny thing with this procedure, at least using the great auricular nerve, is when the patient puts eye drops in their eyes, they can actually feel it tingling in their earlobe. So it's quite entertaining. This is the case that we just witnessed, a 31-year-old with a vestibular resection, and previous facial animation surgery, and he had complete absence of his corneal sensation. You can see the preoperative pentacam here, and then the postoperative pentacam 15 months with the change in corneal sensation. And this is the confocal microscopy showing increase in nerve density 15 months after the procedure. So in conclusion, neurotrophic keratopathy requires close monitoring, but can threaten vision and imposes social, medical, and economic burdens to the patient. Traditional treatments typically do not address the underlying cause of neurotrophic keratitis, and outcomes remain poor in many cases. We believe corneal neurotization directly targets the neuropathology in neurotrophic keratopathy, providing a new source of innervation, restoring sensation, and nerve-derived trophic support for the epithelium. And using peripheral sensory nerve grafts is a promising technique for patients with neurotrophic keratopathy, expanding our ability to restore corneal integrity, and also offers these patients the potential for successful corneal transplantation in the future. Thank you very much.
I request our chair to please ask any questions if we may, or we can introduce the next speaker. Thank you. Requested chairpersons.
Can you hear us?
Yes, ma'am. Now you're audible.
Yeah. So
I'm just asking if you can tell us which are those cases which will really benefit with this procedure or neurotization.
Yes, I mean, I think the patients who benefit the most are probably those with the combined 5th and 7th nerve palsies. They usually have, multiple issues other than just the exposure keratopathy. They have food incompetence because they don't have enough muscle control in their mouths, so it's difficulty eating and things like that. So we often do a combined procedure. But I think, from an ophthalmic standpoint, it's mostly those patients with neurotrophic keratopathy from herpes related diseases that we see most commonly. But, patients that have had prior surgeries, corneal surgeries where the cornea is very not well innervated can also benefit from this. And those are much more straightforward in terms of either using the supraorbital, supratrochlear nerves or inferior orbital nerves, which are almost can be directly used to directly innervate the cornea. The inferior orbital nerve is a very thin, kind of wimpy nerve, and doesn't really have enough fascicles to provide enough innervation in some cases. So it really depends on which neurotization technique you want to use based on the nerves and kind of procedures you're comfortable with.
Yeah, thank you. Thanks a lot.
Thank you.
Thank you, Professor Pineda. We move on to the next lecture. I would like to request Professor Namrata Sharma to introduce our next speaker, Professor Mehta from Singapore.
It is a pleasure to introduce my very good friend, Professor Jodhbir Mehta. He's the head of the corneal service at Singapore National Eye Center, head of the Tissue Engineering and Cell Therapy Group at the Singapore Eye Research Institute, professor with Duke, NUS, GMS, as well as named professor of clinical innovation at SNEC and CERI, director of education, Singh Health, transplant, and executive director at CERI. His work is focused on corneal transplantation, femtosecond laser technology, corneal imaging, corneal infections, corneal refractive surgery, keratoprosthesis surgery, and corneal genetics. To his credit, he has more than 450 peer-reviewed papers in 20 book chapters, has given more than 360 invited plenary symposium and named lectures globally, and has received over 55 national and international awards. Most recently, the very prestigious Casbier Award from the International Society of Refractive Surgery in 2020, and the Charles Tillet Lecture from Fuchs Society, USA in 2020. His research work has generated 15 patents, 5 of which have been licensed to the companies. It is a pleasure to have you, Jod, and he's going to be talking about the molecular basis of the femtosurgeries.
Thank you, Namrata. Thank you for the kind invitation. And thank you for the invitation to take part in the RP Center celebration. My only regret is that we're not there in person to give this talk. Okay. My screen shared?
Yes, sir. Your screen is shared.
Okay, great. Okay.
Nice to meet for this kind of invitation to talk in the 55th RP Center Annual Conference. The title of my talk will be Molecular Changes Following Refractive Surgery. These are my financial disclosures. They don't really contain.
Can you increase the volume? Volume, please. Can you?
Smile and LASIK are two of the most commonly used refractive surgical procedures in order to correct myopia. And even though their functional outcome may be very similar, the way they achieve it is very different. Smile, as you know, is primarily all-in-one femtosecond laser procedure, while with LASIK, we primarily use a femtosecond laser and also excimer laser. In SMILE, the changes to the stroma occur through a closed lasering system, while with LASIK, the stroma body is exposed to and it can be affected by hydration issues during the excimer reshaping. If you look at the outcomes, and most of the studies have, of course, focused on refractive outcomes, when you compare the two surgical procedures, you'll see they're very similar with respect to efficacy, uncorrected vision acuity, and also safety between SMILE and LASIK. But if we look at certain parameters with respect to outcomes, such as ocular surface disease, you will see distinctive differences, especially in the early time point, up to 6 months. And most of these are in favor of SMILE compared to those LASIK. If you look at this in more detail and you look at corneal parameters on the y-axis and you look at it over 1 year on the x-axis, you will see that most of the early time points are showing favor advantage of SMILE compared to what we see at LASIK. But when you get to 1 year, you'll see that the two lines often converge together, showing very little significant difference when you look with respect to 1 year outcomes with respect to clinical signs. And of course, if you extrapolate this out to 4 years, as we showed in our study, we're able to show that clinical parameters are actually quite similar in both cohorts compared to SMILE and LASIK. But one of the things when you're assessing the ocular surface and an intrinsic parameter in the ocular surface recovery is actually the effect on the corneal nerves. And if you look at the corneal nerves in the first year following SMILE compared to LASIK, you'll see a significant advantage in the recovery in the SMILE group compared to what we see in the LASIK group. This is illustrated in these figures over here, where you see the top figures are following SMILE procedure and the bottom ones following LASIK. And most of the parameters that we look at decrease in both procedures, but of course, as we expect over time, they do basically improve. Interestingly, both the procedures will show some damage with respect to the corneal nerves. Typically, we see this as nerve beading, increasing tortuosity, microneuromas, and also basically sparatum. And this can be seen following both these surgical procedures. You can use specially designed software to assess the nerve damage or to assess the in vivo confocal microscopy changes following these procedures, and you'll get 8 parameters from the information using this automated software. So when we look at this in detail over 1 year, what you can see is that when you look at nerve fiber layer density and nerve fiber layer length, you'll see significant improvements in the re-innovation following SMILE compared to what we basically see following LASIK. And these are actually significant up to even 1 year time frame. When you look at branch density and also total branch number as well, these are all significantly better in the SMILE group compared to what you see in the LASIK group. But note that most of these parameters are still down compared to baseline, even from what we see at 1 year. Now, when you look at the area of the nerves themselves, again, you will see improvement in SMILE compared to LASIK, and likewise with the fractal dimensions are superior with SMILE compared to LASIK. But one of the interesting things you see when you look at the nerve morphology is you see the nerve morphology has almost approached baseline in the SMILE group, but it's still below baseline in the LASIK group at 1 year time point. So most of the studies in literature on corneal degeneration and regeneration have actually really been limited to short-term studies in the 3 to 6 month mark itself, and there are very few studies looking at this in the long term. SMILE has significantly higher nerve fiber length density, branch dense, total branch dense, area, and ultrafractal dimension compared to LASIK at 1 year. And this was very similar to our previous published study when we looked at 4-year outcome, where we showed significant advantages in these parameters over SMILE compared to LASIK, maintaining this over at the 4-year time period as well. However, there was no significant difference observed between area, width, and fractal dimensions in the long term. And this may suggest that the nerve morphology recovers before the nerve quantity basically improves itself. Now, interestingly, at 1 year, 3 out of 7 of the parameters have recovered to preoperative levels following SMILE, compared to what we basically saw from LASIK. And in LASIK, actually all the 7 parameters were significantly impaired in the LASIK group itself. And this again implies that the nerve quality recovery of the SMILE procedure is actually superior compared to what we see following the LASIK procedure. But one of the key things about nerve recovery itself, or nerve regeneration, is that it's mediated at a molecular level through the release of neuromédiators. The neuromédiators in the cornea really form 3 groups: neurotrophins, neuropeptides, and neurotransmitters. And their release occurs due to corneal nerve regeneration. And the idea is to return the neuronal function back to normal. You can get a stimulus on the sensory nerves, such as from excimer or femtosecond laser ablation. This will stimulate the nerves to basically release these mediators, and these mediators then will interact with the corneal keratocytes or with the corneal epithelial cells, as you can see in the schematic on the right-hand side. There are 3 groups of neuromédiators: neurotrophins, typically in the cornea, such as NGF, GDNF, BDNF, CNF, and neurotrophin 3, neuropeptides, substance P, calcitonin gene-related peptide, VIP and neuropeptide, and also neurotransmitters such as adrenaline and noradrenaline and acetylcholine as well. If we look at these more specifically, the studies done following refractive surgery, what you'll see is that we just focus on the ones done in humans, that PRK, when you compare PRK to LASIK, LASIK has significantly less NGF release in the early phase at 3 months compared to what we see following PRK. But of course, we know PRK is a high release surface procedure itself, so you're going to get a big increase in NGF levels. If you can look at microkeratome LASIK, you'll see substance P is elevated early on, and CGRP is also significantly elevated at 12 months. This can be related to goblet cell release from CGRP. But if you look at studies comparing LASIK to SMILE, there's actually very few. In fact, there's only one study that's been done that looked at this, and this showed lower NGF levels in SMILE compared to basically what we were seeing previously in LASIK. So we examined this in our patient cohort following over 1 year. And if you look at substance P level, you'll see an initial spike in substance P in the first month postoperatively, and then this basically reduces down to comparator between SMILE and LASIK. CGRP levels also were basically quite similar, with hardly any change in the SMILE group, but a reduction in CGRP level all the way sustained up to 12 months in the LASIK group. Neuropeptide Y with very little changes between SMILE and LASIK, and also compared to baseline. NGF did see a spike in the LASIK group after initial decrease in both groups. There was a spike in the LASIK group, and then this basically settles down by 6 months, while in the SMILE group, following the initial decrease, this is then restored to normal basal levels all the time up to basically 1 year. So what we're able to show from looking at neuropeptides is that LASIK group has significantly higher substance P at 1 and 3 months. And this is basically related to the higher neurogenic inflammation that we see in LASIK cases. The LASIK group has significantly higher NGF at 1 and 3 months, and this may be due to the initial drop that we saw due to the loss of nerves following both procedures, but the rebound release in LASIK is higher than what we see in SMILE, because you've got more active nerve regeneration going on. CGRP and neuropeptide P showed very little travels over the two groups. And if you look at associations, you can see that many of these neurotrophins or neuromediators are associated with changes that we see based on in vivo confocal with respect to nerve morphology. So some of these can be used as biomarkers with respect to nerve regeneration instead of the patient having to undergo in vivo confocal microscopy. But one of the other things that it tells you is that neuromediators are not the only things that are basically having an effect over here itself. And other molecules must be having an effect with respect to how they look at the interaction with the cells in the cornea after refractive surgery. So in order to examine this in detail, we did a proteomics analysis using SWAP, a technique on a mass spectrometry. We analyzed the tear film in 70 patients who underwent LASIK one eye, SMILE in the other eye. The analysis was then analyzed using microarray algorithms to look at differential proteins. We then used gene ontology to look at basically enriched pathways, and Metascape to help us with bioinformatics and the reactor. So these are some of the results that you basically see. This is baseline volcano plots looking at SMILE from 1 week all the basically way to 12 months. And these are comparative grouping, so basically looking at comparative versus baseline. And the first obvious thing that you will see is that there's a lot of protein change at 1 month and basically at 1 week following the initial refractive procedure. And this settles down basically when you get to 6 months, but 12 months. But even at 12 months, you will see that there are still some proteins that are highly regulated and some that are downregulated compared to what we see at baseline. So your molecular pathways are still changing even at 1 year following your refractive procedure. If you look at this in a little more detail and you look at the proteins over here, the ones in red are upregulated and the ones in blue are downregulated, and this is linked to their pathway of activities. It's difficult to see this on the screen, but we will talk about this in a little bit later about them in detail. But what you can see is that many of these proteins and many of these pathways are still interacting even up to the 1 year time frame when you see these patients following their refractive surgical procedures. There's still activity, upregulation, downregulation of certain genes, even at basically 1 year. If we look at the same thing following LASIK, again, you see a similar picture. where you see a lot of upregulated downregulated genes at 1 week and basically 1 month, but even up to 1 year on the volcano plots, you see the same thing where you see a lot of upregulated and downregulated genes as well. Likewise, when we look at the dendrome here, you'll see a similar picture where you'll see a lot of upregulated genes in red, downregulated in blue, but a lot of complex pathways occurring not only in the early time frame between 1 week and basically 1 month, but also at 3 months and also at 1 year following the refractive surgical procedures. There are many proteins that are still upregulated, having an interaction at a molecular level following the refractive surgical procedure. So what about between the two groups? So when you compare SMILE to LASIK, what you'll see is the preoperative levels in our baseline group, there was no significant difference. And you can see here, there's no blue dots or red dots showing upregulation or downregulation of genes. But once you start going from 1 week all the way to 12 months, you can see at 12 months, there is still significant difference with respect to upregulated and downregulated genes between a SMILE and LASIK cohort. Again, if we look at this in a little bit more detail, you can see this basically on the pathways in the upregulated and downregulated genes. And if you look at D, which is basically at 12 months, you'll see that even at 1 year, there's significant difference at a molecular level between SMILE and LASIK. So the molecular process is still going on even at 1 year postoperatively. If you look at this in a little bit more detail to get an understanding of common pathways, what will this tell us? What this shows us is that complement activation and immunoglobulin production were the dominant responses following both SMILE and LASIK. When you look at 3 months post-operatively, the immune response persisted, and then cellular metabolic processes were also upregulated. Typically, we saw proteins such as apolipoproteins, immunoglobulin family, and complement cascades and fibronectins. And these are involved in immune regulation, and generally these are pro-inflammatory proteins involved in the immune system, and also basically in NK cell activity as well. Fibronectin 1, of course, we know is associated with extracellular matrix wound healing itself. From between 3 months and 6 months, we still have an upregulation in the immunoglobulin proteins from both groups, but we also have upregulation of 2 other proteins as well. And these are proteins that we see that are usually found in situations where they're trying to compensate for ocular cells, especially in the epithelial surface, and also basically can be associated with dry eye. At 12 months, we still see higher levels of T endopeptidases, and these are typically secreted from goblet cells, so typically from MUC-L1 and MUC5AC itself. And these are often found where we see episodes of wound remodeling in response to stress, to protect the ocular surface epithelium and to basically prior lubrication. So these processes are still going on even at 1 year postoperatively. Now, if you compare the 2 surgical procedures, are there any obvious differences? And the answer is yes. If you look at 1 month, you will see that there is greater humoral response, wound healing, apoptosis, and neutrophil migration following the LASIK eyes compared to what we see in SMILE eyes. So the response back from the body is higher in LASIK compared to what we see in SMILE. At 3 months, we see high levels of reactive oxidative species such as SALT2 in the LASIK group compared to what we see in the SMILE group. And typically, this is a protein that's secreted to mop up high levels of reactive oxidative species. But even at 1 year, you will see high levels of proteins associated with tight junction repair and proteins that are downregulated in LASIK that we normally typically see downregulated in patients who are associated with dry eyes due to a dysfunction in the lacrimal arc reflex. And this is still being seen in LASIK eyes, but we're not seeing this basically in the SMILE eyes. So in conclusion, despite clinical signs returning to baseline levels at 12 months in most studies, the biological healing response following refractive surgery is still ongoing even at 1 year. Nerve regeneration is superior following SMILE compared to LASIK in the first year, with 3 out of 7 parameters returning to baseline versus 0 out of 7 following LASIK. With respect to neuromediators, NGF and substance P was significantly altered after LASIK compared to what we saw in SMILE, and this is associated with nerve fiber matrix changes that we basically described earlier. Molecular proteomic changes showed ongoing tissue wound healing responses even up to 1 year following both procedures. LASIK had greater leukocyte migration, humoral response, wound healing, and apoptosis and endopeptidase activities compared to what we see following SMILE. And some of these proteomic changes that I've shown you can be subsequently used as biomarkers with respect to understanding in more detail what is happening at a molecular level to help patients with respect to unusual symptoms or patients who are having ongoing problems following their refractive surgical procedures. Just want to thank you for your attention, and I'm happy to take any questions. Thank you.
Thank you, Professor Mehta. Are there any questions from the panel?
Yeah, Joe, wonderful talk. So you said you could compare the apoptosis in LASIK versus smile, right?
Yeah.
You must have done the tunnel, Nick tunnel assay. I mean, that's what I think is the standard.
No. So this is done with tear samples, and then that's how we get the protein levels. Previously, we've published on how to compare apoptotic markers versus SMILE versus LASIK, but that was obviously done in rabbits because you need the tissue. But this study is done on a protein level from tear samples.
So do you think it's a true reflection of the corneal changes onto the tear? Because we did something on the rabbit side in which we realized that if we could give calcium chelating agents, this was about 20-25 years back, we did the surface ablation, and then we found out with the tunnel assay, because we had the tissue to check with. So tear might not be a true reflection. I'm just contemplating.
Yeah, sure. Yeah, so that's a good point. And of course you're using tear as a surrogate for what's basically going on at a tissue level. The main thing is you have to bear in mind that these patients are RCT, so it's the same patient having contralateral eye surgery. So you have the same individual. So you would expect if you would expect the same response if the true biological response is the same, you see, because obviously it's the same individual. So it's not that you take a cohort of like 80 patients and maybe another 80 patients as well. So we can neutralize basically a little bit for that. Of course, you can never take sample, from a patient. So you're using it as an idea. But the point is that we know that the nerve denervation and then the reinnervation is closely linked to the neuronal lacrimal arc system itself. So we know that plays an issue, you see, following any refractive surgical procedure. So that's why I think that using the tears as a marker actually is quite interesting. And also, if we're looking at maybe making a kit or a dipstick kit from some of those proteins that we were able to see at 1 year to maybe help you differentiate patients who are at risk or patients who have maybe still having issues with instability in their tear film.
Yeah. Food for thought. Can you just pick up the scavenger, take the air which you ablated? Can you just compare those ones in LASIK? SMILE, you can get the tissue out because you get the lenticule out. The LASIK is the issue. So can you just take the air which is coming out using the scavengers like the anesthesia people use?
Yeah.
So can air be used for
anything?
Molecule?
I think people have done, the one area that's sort of very hot topic now is metabolomics. So you can take your lenticules from SMILE and look at the metabolic changes, and omics is a big area, and we were obviously initially in genomics, and now we're sort of like genomics, proteomics, and now we're basically in metabolomics as well. But metabolomics, you need tissue. I mean, you could dissolve gas into a liquid phase to then basically take to examine metabolomics, but you'll need still quite a reasonable quantity to be able to do it.
You can do it in Singapore. We can't do it in India. So I just thought I'll let you know. Thank you very much.
Thank you, Professor Mehta. Our next speaker is Professor Chi Soon from Singapore. I would request Professor Jeevan S. Titial, Chief RP Center, to do the kind introduction.
Thank you, Dr. Tanuj. Indeed, it's my pleasure and honor to introduce our dear friend, Professor Chi Soon Phaek from Singapore. She's a world-renowned surgeon, and she's always omnipresent in various conferences, including India. She is a senior consultant in cataract and comprehensive ophthalmology department and ocular inflammation in immunology department at the Singapore National Eye Center. She has done fellowship in uveitis and oculoplastics, lacrimal and orbital surgery at world famous Moorfields Eye Hospital, London in 1993. She is the president of Asia Pacific Intraocular Inflammation Study Group, APIISG, since 2013. And she is a member of several editorial boards, including Ocular Inflammation and Immunology, Journal of Ophthalmic Inflammation and Infection, and Journal of Cataract and Refractive Surgery. She has authored more than 200 peer-reviewed scientific papers and book chapters, and she has received multiple awards, notably the Best Teacher Award in SNAC in 2000, the Outstanding Clinician Award in 2011, and the Singapore Health Quality Service Award in 2014, a gold medal for her significant contribution to national health care. And she'll be talking to us today on a very important topic of pediatric subluxation and its management. All to you, Chi Sun Fik.
Thank you so much, Professor TTL. Could you please play my video? Hello, everyone. First of all, I'd like to thank Dr. TTL for inviting me, and I'll be speaking on management of the pediatric subluxated lens. These are my financial disclosures with no relevance to my talk today. The causes of congenital lens dislocation include isolated ocular disease, which may be a simple ectopia lentis, which often is bilateral, dislocates mostly in the superior-temporal direction, or ectopia lentis at pupillae, which is often bilateral, and the lens and pupil are displaced in the opposite directions. Or there may be systemic associations, the most common being Marfan syndrome, where the lens shifts superior nasally, homocystinuria, where the lens moves in an inferior or nasal dislocation, microspherophakia, where it dislocates superior temporally, inferior nasally, or inferiorly, and a whole host of other causes, as you can see here. There are many challenges associated with managing the pediatric subluxated lens. Firstly, the timing of surgery. This should be done only when vision is no longer adequately corrected by spectacles, or when the lens equator bisects the visual axis, and is urgent when the lens is subluxated into the anterior chamber or posteriorly. How about the type of intraocular lens? We should usually use monofocal and even toric lenses if we can ensure that the lens is well secured, and perhaps in the near future, even consider the use of enhanced depth of field lenses. So how about the technique? Really, from the literature, there is no clear superiority of one technique over the other. We may consider either to discard the lens bag or to preserve the lens bag. If we discard the lens bag, we can consider the implantation of an anterior chamber lens, although mostly, especially in children, we are moving away from the use of anterior chamber lens. An iris enclavated lens, especially if enclavated posterior to the pupil, may be considered. Scleral fixation of the intraocular lens, either using sutures or in a sutureless technique, is a good option. However, if we are able to preserve the bag, we will be able to implant the intraocular lens into the bag and use capsular tension rings with capsular tension segments to secure to the sclera. In addition, if the child is older, we may consider the use of femtosecond laser in order to scan the capsular bag and place the capsulotomy in the center of the capsular bag in the desired size that we may choose. This child with Marfan syndrome has a subluxated lens. I first created a scleral tunnel, 5.4 mm in size, and then puncture the capsular bag with a 27 gauge needle, initiate capsulorhexis and do bimanual capsulorhexis, support the lens bag with iris hooks, aspirate up the lens, and then do a vitrectomy with the help of 50% diluted triamcinolone acetonide in the anterior vitreous, as well as remove the capsular bag. I then constrict the pupil with myostatin and inject dispersive viscoelastic into the anterior chamber, enlarge the incision, and then flip the artisan lens such that the concave lens surface is forwards, rotate it to horizontal meridian, grasp the IOL, and push one haptic behind the iris and lift it up so that I can see the profile of the claw as I enclavate it with the enclavation needle, and repeat this with the other claw. First push the claw behind the iris, then lift it up so that I can see the profile, and then I enclavate the iris into the claw. And importantly, finish by creating peripheral iridectomy superiorly to prevent iris pupil block. This is a teenager with Marfan syndrome in a small capsular bag. I puncture the capsular bag with a 27 gauge needle to initiate capsulorhexis, and then do bimanual capsulorhexis by grasping 1 inch of the capsule with non-tooth forceps as I tear the capsule with micro capsulorhexis forceps. Once I finish the capsulorhexis, I then inject dispersive viscoelastic under the anterior capsule to create space for me to insert this capsular tension segment, which has been preloaded with 9O polypropylene suture. And once I've done that, I insert an iris hook to hook onto the eyelet or the capsular tension segment in order to expand the capsular bag. And once I've done that, I aspirate the lens and do an F-external method to fixate the suture through a Hoffman pocket at a point 2 mm posterior to the limbus by railroading the suture needle into the 27 gauge needle. I then throw 3-throw knot to expand the capsular bag as I inject a capsular tension ring to expand the equator of the bag and to support the equator. Now I've done that, I'm going to prepare the toric RL to insert into this lens bag, and I do a rotation to the axis quite quickly before the lens expands so that it is easier to align it appropriately. And once I've done that, I complete the knot after the 3 throws with 2 further knots to center the RL. Now, this patient with Marfan syndrome, we are initiating the capsulorhexis and tearing this time without the need of support. And the shape of the capsulorhexis should be the shape of the lens. We then support the capsular bag with capsule retractors that support the equator of the lens bag. And you can see the plane dissected again cleanly by this viscoelastic into the subcapsular space. And once we apply traction to these hooks, they then expand the bag to the normal position so that after doing lens aspiration, we can then insert a Sioni 1L capsular tension ring, which is modified with a suturable eyelet. We then remove this support because I'm worried that I may have threaded the ring through the wedge of the support. Now, this next patient has a lens dipping into the vitreous cavity. This patient is isolated microspherophakia, and I've just harpooned the lens with a 27 gauge needle and brought it to the anatomical position and doing bimanual capsulorhexis again and using an iris hook to support the capsule rim as I tear, looking at the equator for guidance for the shape and the size. You can see as we add more supports, we can then complete the capsulorhexis. It's difficult when you do not know where the center of the lens is, and retracting the iris helps us to know. And once we've supported the lens bag, I'm preparing the suture snare by preloading a 26 gauge needle with a segment of this Cortex 7.0 suture. I apply a capsular tension segment, the capsular tension ring in the subcapsular space, another segment, support them, aspirate the lens, and then we're going to implant the intraocular lens into this bag and marking 1.75 mm posterior to the limbus is to show you the dissection of the Hoffman pocket, half scleral thickness using the suture snare, extend a loop of the suture, as you can see here, out through the main incision, and then bring in a suture through that loop of extended suture to lasso this end of the suture bearing the capsular tension segment so that we can bring it to the scleral fixation point, 1.75 mm posterior to the limbus, and then retrieving the sutures from the Hoffman pocket. We then apply a 2-1-1 knot, adjusting the tension to center this intraocular lens. We ensure that the knot is well buried. This 2-year-old has a traumatic subluxated cataract. I initiate capsulorhexis with the 27 gauge needle, then do an interior capsulorhexis with the microforceps. And as I'm tearing, you'll see pseudoelasticity displayed here. And I insert a capsule retractor in order to provide the counterforce as I continue my capsulorhexis. And you'll see this is much easier and smoother. But when I come around where there are no zonules to provide the counterforce, you will see that this is again difficult to perform. And I should have used bimanual capsulorhexis here. I was a little lazy and just tore on, and you see this capsulorhexis tending to run out. And at this point, I bring on a second microforceps to provide the counterforce and complete the capsulorhexis safely, although it was a little larger than intended. I then support the equator of the lens with capsule retractors and do lens aspiration. And when I come out of the anterior chamber, I inject dispersive viscoelastic to maintain the anterior chamber space. I then create a Hoffman pocket half scleral thickness 1.75 mm posterior to the limbus, and then load a capsular tension segment with cortex 7O, insert it into the capsular bag where the zonules are missing, and I create a suture snare using 26 gauge needle loaded with the cortex suture, extend a loop of the suture, and lasso the free end of the suture loaded on the tension segment and bring it to the scleral fixation point. I repeat this step with the other end of the suture, and both sutures are then brought to the sclera. I puncture the posterior capsule now with a 27 gauge needle and do a posterior capsule rhexis. You can see the posterior capsule is really elastic, and as I pulled the capsular tension flipped out of the capsular bag, and I managed to reposition it, put 2 throws to apply some tension as I insert the intraocular lens into the capsular bag, and then finalize my knot with 2 further throws to center the intraocular lens, and then remove viscoelastic. This patient with microspherophakia was done with femtosecond laser-assisted cataract surgery. We are first scanning the capsular bag and then downsizing the capsulotomy to 4 mm, and you can see that the capsulotomy is done in less than 2 seconds. As microspherophakia, after doing the capsulotomy with the femtosecond laser, I then remove the capsule, checking for the integrity of the capsulotomy. And this area here was a little uncertain, so I used a second instrument to help to remove the capsule and found it was intact. I then provide supports by inserting capsule retractors just under the capsule and then insert a capsule tension ring into the similar space. And I did not provide the counter traction on this other side here because I was uncertain of the integrity. And then the rest of the surgery involves inserting 2 capsule tension segments and fixation after RL insertion. Now this is to show you a patient where the lens is subluxated into the vitreous cavity. We're now marking diametrically opposite positions, 2 mm posterior to the limbus, and then we're going to remove next the lens with vitrectomy through a pars planar approach, do a peripheral iridectomy, and then inject dispersive viscoelastic into the anterior chamber and insert a 3-piece intraocular lens into the anterior chamber. And then we're going to use 27 gauge needles that are bent, and we moved from 2 mm away from that predestined mark and insert through a scleral tunnel into the eye and thread the 1 haptic into the bore of this 27 gauge needle. We repeat the same for the diametrically opposite point, ensuring that we are entering the eye at the marked position. And then again, threading this haptic into the bore of the 27 gauge needle. We retrieve the 2 ends of the haptics by pulling simultaneously, remove the needle, flange the haptic as it comes through. And once we ensure that the lens is well centered, we then can push this back into the scleral tunnel. So the pearls for managing pediatric subluxated lenses include the use of bimanual capsule rhexis or iris hook for severe zonulisis to provide the counterforce. The shape of the capsule rhexis should follow the lens shape. Use capsule retractors or capsule tension segments for equatorial bag support. Delay placement of the capsule tension ring, but in severe cases like what we saw here, mostly we should place the capsule tension ring before the lens aspiration. I today would recommend you the use of Cortex 7O suture, which is off-label for ophthalmic use in the USA. However, it has great longevity and great strength and is easily handled. Thank you very much.
Thank you, Dr. Chisun. That was really a fascinating demonstration of surgical prowess in pediatric cataract surgery. And are there any questions from the panel?
Yeah.
It was a great talk. I just wanted to know whether the PI is needed in the retrofixated lenses, And the second question, I saw that quite young children are being operated. So how do you decide on the IOL part? Do you do undercorrections or do you follow a different nomogram?
Okay, so thank you for your questions. I definitely want to do PIs, and sometimes I even do 2 PIs for enclavated IOL. And I mean, I do PIs routinely, not just for enclavated IOLs, for iris fixated IOLs, for Yamani fixated IOLs, for almost any kind of fixation, because sometimes we do get the iris being quite floppy and actually going behind the optics. And this, of course, this is the experience that I've had basically in handling so many adults who have, possibly floppy iris, and there isn't the capsule there to prevent the pupil capture of the optic. With regard to the, sorry, what was your second question?
IOL power.
Oh, yes. Okay. So normally I would have these cases referred to me by my pediatric colleagues, and I would actually consult them. But generally, when the child is about 6 years old, we would target for plano, and below that, we would target for hyperopia, and it would probably be from like 2 years old to 6 years old, would be graded down from 0 at 6. And then for a patient who's like 2 years old, that would be like probably like 4 diopters. Yeah, anything beyond 6 diopters, we would probably just give them a plano outcome.
Okay, thank you.
Thank you very much. Now I invite Professor Sudarshan Khokar to introduce our next speaker, Professor Ibiro.
Okay, so they say the life begins at 40, but I think they're going to change the nomogram now. So life actually begins at 33, as we're going to listen to our colleague from Portuguese. So a little bit of introduction. She's a professor, faculty of medicine in Lisbon since 2010, and specializes in cataract and refractive surgery. Presently, she's a director of the ophthalmology services at the Luz in Portugal. She was elected. She was the only person to be elected in the last 20 years on the panel of the Portuguese on the ESCRS board. So that speaks a lot. She's a co-member of the board of the European Society of Cataract and Refractive Surgery. And she has authored numerous articles. When they say numerous, I presume it's in 3 figures. That's why they don't mention, because they're so humble, and especially with a PhD degree, I know. So welcome. So I'd like to call you Bem-vinda, Simonia Hibario.
Many thanks. Thank you so much for the kind invitation and the kind presentation. So I'm really happy to be here and share with you my experience, and I will share my screen. I think you can see it. Can you confirm? Yeah? Okay. So I would like to share with all of you my experience with continuous range vision intraocular lenses, and what can then provide to the functional vision that our patients really needs. So we know that presbyopia correction IOLs, they still have some flaws, but the last year's evolutions were very meaningful for the use of this intraocular lens. We can address the issue of the dysphotopsia and quality of vision, and we have now intraocular lens with spherical and chromatic aberration correction, so they can really provide more quality of vision. And we still need to keep in mind that the first issue for dysphotopsia and bad quality of vision is the residual refractive error after the cataract surgery. And for that, in the last years also, we have a great improvement in biometry and IOL power calculation, and also more tolerant IOLs. But I would like to remain that if we listen to our patients after presbyopia correction, intraocular lens implantation, we saw in this inquest for ECRS that our patients complain more about not having the intermediate vision they need to perform their lives. Even with monovision strategies or PC, IOL strategies, the same complaint from our patients. And it's true that this is about the performance ability and the vision related with all the kind of activities that we have in our daily life. And right now, we need to address this, understand better the needs of our patients, because we have an aging of population. We start with a project at our department to understand a little bit more about the needs of our patients. And this graph that I'm showing you is a pre-op evaluation of 32 patients with a device that can register all the working distance for our patients. They use the device 3 days, and then we can assess the needs of our patients. And if you see the needs for intermediate vision, they are high. That's why our patients are complaining. And if we see the near plus the intermediate vision, really is very relevant for functional vision after cataract surgery. And we need to understand that we have to address this issue just before the surgery. Either we correct the presbyopia with intraocular lens or after with some kind of prosthesis. We also know that, for instance, the progressive glasses have some kind of problems, even with falls of our early patients, which is a health public issue. And presbyopia is a chronic disorder, dysfunction. And if we see the impact of impairment of distant visual, we need to assess that there is a reduction of quality of life, but is even stronger, at least for physical, physiological, and social domains for the near vision. And impair of near vision represents about 4% of reduction of overall quality of life. So we need to understand better what is the needs of our patients. And I bring you here a paper by Fernando Soler from Spain, and he tried also to assess the working distance and also the mobile phone usage distance for different job profiles. And we can see here mainly a great difference if we are talking about militaries. They have a longer working distance. But for instance, if we see the show factory operator, they have a working distance that is inferior to 40 centimeters. And the truth is that mobile phone usage is really relevant in our days. And in this graph, he can show us how 88% of the persons assessed, they have a mobile phone usage distance that is inferior to 40 centimeters. Also, he could not assess any correlation statistical significant between working distance and the mobile phone users distance, but we see that there are some difference between gender in working distance, but not for the mobile use. And this is a difference from gender, but also we know that there are different needs for different kind of populations. And this paper also brings the issue that for instance, Chinese population have a usage of the mobile that is 2 centimeters closer than American people, for instance. And that the reason that we try to explain this with difference in spatial frequency in different language scripts. Okay, so addressing intermediate vision is a need. And that's why we have an evolution towards EDOF IOLs. And the first one was Symphony, as we know. We have a great experience with the Symphony. We published this experience. And as you can see, even in these more stream eyes like post-LASIK cases. And if you can see in this graph, I'm sorry, you see how we can, with this EDOF strategy, improve intermediate vision when compared with the monofocal IOL without significant loss of contrast sensitivity. Also, different strategies we saw appear, like these combined EDOF to address the intermediate vision and combine with a multifocal IOL, which is a diffractive bifocal IOL from J&J. And you can see, comparing Panoptic's IOL with this combined strategy, that we can improve this range of vision from far to near. What about contrast sensitivity? We have also an improve in photopic contrast sensitivity, but most impressive is the improve in mesopic conditions. And right now, the working day is more about mesopic than photopic. And seeing this is natural, seems natural, that appears a technology that can combine these two principles. And that's why we have Technis Synergy to try to provide this continuous vision without any dependence on the diameter. Also addressing this issue about correcting spherical aberration and correcting chromatic aberration, and also adding a violet light filter. Well, we have published our first results with this IOL last year, and I would like to show you some of our results. First, we have here the refractive results. As you can see, these all were IOLs, spheric IOLs, no toric correction, so low astigmatism patients below 1 diopter. And you can see in the spherical equivalent, we can have, in average, a very good refractive results. And also if we see to the dispersion of these refractive results. So what about visual acuity? So we assess the visual acuity in photopic conditions with, as you can see, very good results for distance, intermediate and near vision, but also we can have these very good results when we assess the visual acuity in mesopic conditions. And this is really a great improvement in presbyopia correction IOLs. So for monocular far vision, we see that 100 of our patients have 0.3 logmar or better, and almost 100 with 0.1 logmar or better. We can see in binocular vision for all distance, we can have at least 0.3 logmar or better. And this is the focus curve for this IOL. as you can see, can provide a very continuous vision, not with the valleys and peaks that we are used to see with trifocals or bifocals IOLs, but a continuous range of vision with more or equal 1.1 log mark. And this provides to this IOL an indistinct head power, a really continuous range of vision with this broader peak distance vision also. So this IOL addresses this issue of functional vision because can allow different working distance preference without losing of contrast sensitivity, and our patients were very satisfied with 8% of the patients saying that they have no difficulties in functional vision in their life. Well, with these good results, of course, we also wanted to compare these results with the other trifocal IOLs that we are using at our department. And as you can see, this was also published last year, and we compared the synergy with the PanOptix and the fine vision IOL. And if you see for intermediate vision, the intermediate vision uncorrected was better for the synergy group. And for the near vision, we have a significant better compared with the PanOptix group for the focus level, as you can see more extreme. So this IOL provides a very good near vision also. So we have higher visual acuities at every distance, and for near vision, one line of more related to the synergy group. Most impressive also, the contrast sensitivity of these patients in mesopic conditions with glare. And as you can see, there is a significant better quality of vision under mesopic and low contrast conditions for the Technis synergy group. What about dysphotopsia? This is the comparison of these the three IOLs. As you can see, there is no statistical difference between these three IOLs in dysphotopsia. So G&J address this issue about intermediate vision with the two new strategies that are very useful to address the functional vision of our patients. And these are graphs of our pre-op of our patients. And if we have this kind of needs of all working distance for our patient, this hybrid, this combination of trifocal and EDOF is a very good solution. If we have more intermediate needs, well, we can have a need of a solution like Symphony, or if we have more need for far vision and intermediate vision, an enhanced monofocal like IANS could be a very good solution. Just to compare all the family Technis, as you can see, comparing IANS with the Technis monofocal, we can improve a little bit in intermediate vision, and comparing Symphony with Synergy, we can improve the near vision for our patients without compromise the contrast sensitivity and without increasing dysphotopsia issues for our patients. Just to finish, I would like to show you this graph. This is from a patient with the bilateral implant of a Synergy IOL, 1 month post-op. She agreed to use the Vivior device for 1 week. And as you can see, this patient really use all working distance. Thank you so much.
Thank you very much, Professor Bero. We move on to the next talk. It's a privilege and honor to introduce Professor Michael Coote from the Royal Victorian Eye and Ear Hospital, Melbourne, Australia. He is one of the leading clinician scientists of the Asia Pacific region, has previously served as a director of ophthalmology at the Royal Victorian Eye and Ear Hospital. He is a very active in glaucoma surgery, both as a surgeon and in basic research, and has developed the serum model for bleb porosity, and also developed the glaucoma optic neuropathy project, which has been published in the World Glaucoma Association education section. He currently serves on the executive board of the International Society of Glaucoma Surgery and has been on the program chair for various international congresses. So it's a pleasure to introduce Professor Michael Coote. And Michael, the floor is all yours. Thank you.
Tanuj, thank you very much. And hello to everyone. Many thanks for the invitation to speak, and congratulations to the institution for turning 55. It's slightly younger than I am, but not by much. So I'm going to share my screen now. I hope that works satisfactorily. I'm talking today about some of the changes that are going to happen, maybe not for every patient, but certainly for a significant proportion of patients, who, particularly those who are having trouble with the surface. It was quipped, I think, by one of the English ophthalmologists, glaucoma doctors, that the greatest symptoms that people had with glaucoma in his clinic were from the treatment that he was offering. And certainly most of our patients in glaucoma clinics are using drops. So this is a little bit of a peek into the future. I have some disclosures and certainly worked with Allergan and Polyactiva in some of the early studies in these things. We know that there are a lot of issues with drops. In fact, having done this now for a great number of years, I still find it quite surprising that drops get in eyes at all. They're against a hydraulic gradient and against a fairly significant object, the cornea. But what we do know is that we have much more drop on the surface of the eye and the tissue around it than is necessary, and that quite a lot of our patients really can't administer them with any accuracy. And without watching patients, but certainly the studies that have been looked at, a great number of patients actually will miss the eye at least a number of times. There's a lot of contamination of bottles, and in many cases, the drops are discontinued. So we have this problem with drops, is that they're not happy bedfellows often with our patients. We also know that one of our major agents, the prostaglandins, causes a great deal of ocular side effects, which really increase with time. And those, again, of us who are approaching the same age as the RPC know that long-term use of prostaglandins produces significant changes to orbits and lids, some of which can be very troublesome and very difficult to manage. So the use of sustained use agents that potentially can target tissue better may well improve things. And again, this is in line with what we think of as precision medicine, the idea that we can target material exactly to the organ that's used. There's a study that we did with dogs, but also this is from Allergan's original data. And what you can see when you use a topical agent is that there's an enormous amount of bimatoprost into the tissues. Now, admittedly, this is in dogs, but if you sample it all the way back into periorbital fat, you're going to see that bimatoprost makes it all the way into that and into the upper lids and into the conjunctiva, of course. And so one of the challenges, of course, is to put these drugs where they're needed without putting them where they're not. So there's a bit of a run through some of the things that are coming over the horizon. I'm sure some of them will fall. Is there an issue? I'm sorry. No. Some of these may fall as we continue, but they are at least in development, some of them. So one of them is Kedalian therapeutics, which is a process of reducing the volume of material. And it does atomize material and put it into a much smaller and more precise dosing. It's quite good, although there's some issues with how it's handling drug and its capacity to use preservative-free agents. Soaking contact lenses with bimatoprost, timolol, or dazolamide seems to do quite well, but of course the contact time increases quite significantly with these agents. Punctal plugs have been tried. I think, in fact, there's been a number of different agents that have been put in, but certainly with glaucoma agents, they exist within punctal plugs that either release through the center of them or the whole plug dissolves. They are a way of increasing compliance, but unfortunately probably not a way of reducing orbital contamination with the agent, and so perhaps are not going to progress as much, but certainly they've been around. This is one that we were involved in initially for Foresight Vision, which is actually, I think, subsequently was sold to Allergan. And what it used was a ring, a thing that in fact encircled really right up in the fornix. I wore one for a while just to see broadly what it was like without drug in it. And it's actually reasonably comfortable. They were able to be put in and left in for 6 months. There was sometimes a little bit of mucus attached to them and things. But in fact, they did produce good efficacy and in fact, a high level of retention and a high level of patient satisfaction. Again, the problem here was that the material that was released was prostaglandin, and prostaglandin, of course, released into the orbit produces issues. So it didn't really solve the problem of targeting prostaglandin particularly to where it's needed, which is broadly the inside of the eye. Putting it around the outside of the eye increased the bulboconjunctival reaction. But it did work, and it was effective, and in fact, I think is still sort of languishing a little bit in the development space, but certainly there was good evidence that it worked. They were effective at keeping pressure stable, and of course, although we don't get a lot of diurnal variation with the pulsed nature of drops with prostaglandins, we do still get some, and it evened that out quite well. There is, of course, coming with Glaukos with an eye dose. You may have heard of this. It's a sort of, in a sense, an augmented eye stent. It's not clear kind of really whether or not it will be for the drug or for the eye stent. And this is still in development. It is an interesting idea. The question of whether or not there is a significant benefit from the drug is complex. If you understand anything about material development and implant development, the addition of a drug to an implant can make it much more complex in a regulatory environment. And this, as I understand it, is meeting some of those complexities. So one of the key areas is in intraocular implants. And really there's been quite a few of them come through. The one that currently exists on the market is Durista, which is a bimatoprost slow release form. It's in a PLGA base. It is at the moment limited to a single dose, although there have been a number of phase 3 studies that have involved multiple dosing. Polyactive, which is a Melbourne company and one that I have been working with, is using a different chemistry to allow really truly zero order release, which is through some quite clever manipulation of joining molecules, and it seems to be performing well, certainly the studies that we've done, and I'll show you some photographs of that implant in a moment. They are quite capable of producing sustained falls out to 6 months. Ocular therapeutics, which again is languishing just a little bit. A number of these have a PLGA base, and PLGA may be causing some of the issues. But of course, basic principle of having intraocular implant is that it doesn't itself cause problems. Its administration is relatively straightforward and non-traumatic, and that the material that is used as a base of it does not in itself cause issues. And that is a problem, although again, polyactive is probably a bit of a front runner with that, as it's dependent on, well, at least the surrounding material that holds the active drug completely resolves with time. So here's some photographs with Durista. These are actually from my own collection of patients that we had in Durista implants. I'll include the one on the top left-hand side, as just on the odd occasion, the implant would catch on the insertion point, so that is hanging there. It's put in through a modified 27 gauge needle through the limbus of the cornea. It does swell a little bit after time, so you'll notice that there's a little bit of a change in appearance if you follow the top left into the bottom left, top right into the bottom right. That's its essential aging process, although they're clearly not all the same person. There is still a residual implant after the drug has eluted, and the last process, the drug eluting, is sometimes less predictable than we'd like. Polyactive implants are things that have, they are certainly longer, so you can see this clear tube-like structure sitting down in the angle, and over a period of time it will dissolve, but it tends to dissolve really quite rapidly at the end and stay more or less the same shape for most of its period in the eye. It's not terribly easy to see, which I suppose in a sense aesthetically is a nice idea, but actually can be quite tricky to identify where it is. It comes in sort of different lengths. In fact, that's one way that the amount of drug being released is adjusted, but it's still in its early phases, but certainly the early work does seem to be quite promising, and it is a technology that can be used for other materials such as intracameral fluoroquinolines for use either post cataract surgery or in fact in the treatment of endophthalmitis, which is also work that is ongoing. One of the things that we found when we did these studies is the loss of prostaglandin side effects, which, to be fair, we don't often identify. We can sometimes see it post-surgery, but in this instance, this man continued with his Lumigan in his left eye, his bimatoprost, and his right eye had a Durista implant. And you can see the resolution of the darkening and the lash growth and some of the changes in the upper skin fold of his lid, which occurs really within the first 6 months. Most of these implants, as I say, landed for about a 6-month use. This is the future, which is quite crowded at the moment with a number of products. Of course, a number of these will fall away as they don't pass, but it is quite a busy area. And of course, some of the technology that is used in this space will be applicable to other areas, such as in the posterior chamber. Use of biologics in erodible polymers is quite complex, and that poses the most challenge. So having long-acting vascular endothelial growth factors or nerve growth factors, which are things on everyone's mind, they're quite difficult to put into sustained release formulations. Now that's all good, but of course there's quite a few areas that they haven't really or may not really work as well as we hope. So here's a kind of list of them, and I think there is, there possibly is more as we go through. But the first, of course, is just the value. Are they actually cost effective? I think we've had some wonderful talks before about corneas that are either diseased or intruded on in some other way. And there's no doubt that its value has to be in reducing side effects and problems with corneas and surrounding tissue. And sometimes that might be a bit hard to quantify, but broadly, if they're substantially more expensive than the equivalent drop, then it will be at times hard to justify. And so we'll have to kind of be clear about what a cost-effective outcome is. We all grapple with it. I don't think we quite know how much a millimetre of mercury fall from any kind of intervention should cost. I guess at some stage health economists will provide that information, but at this stage we are free to choose, at least for the most part, and also of course depending on patient choice. There's a safety aspect, and one of the things that has been clear, certainly with the PLGA devices, is endothelial loss. It stays at a fairly low level, although on occasion there's been some SAEs in some of the studies in relation to endothelial loss, mostly related to how many implants are in the eye at the time. PLJs do disintegrate into a kind of an acidic slurry, at least a little bit, and potentially that might be part of it. There is obviously inflammatory sequelae if the implant moves or if there is an abrasion to the endothelium, but inflammation, infection, and endothelial loss are obviously the most compelling risks associated with putting implants in the front of the eye. Although, of course, all of our experience with injections to eyes has changed markedly with the treatment of AMD and diabetic retinopathy. The length of efficacy needs to be at least 6 months, and we're still seeing some stuff that doesn't seem to make that. There is variability in effect still, although that happens with topical agents as well. And there's an idea currently, whether or not it has merit, but there is pharmacosurgery. This is a term coined by Mike Robinson at Allergan, but the idea that there is a prolonged effect in some people from prostaglandins that may be helpful. And finally, I'd make the point, although I haven't been a great fan of episcleral venous pressure as a cause of glaucoma, except in obviously the obvious circumstances, but there may be some merit in this. There is topical agents, topical prostaglandin agents do cause a reflex vasodilatation of the anterior and reflected vessels in the conjunctiva, whereas intraocular administration of prostaglandins does not do that. And that reduction in that area of vasculature may well be very important. Thank you. That's a little glimpse into that. I do hope you have a good meeting. And I'm sorry we can't be with you. It is, yes, COVID's a mess. Thanks, Tanuj.
Thank you, Michael. I know it's very late for you. So just one question for you. Like sometimes we have allergic reaction to the eye drops. So have you had any cases where you had an allergic reaction to these implants?
Yeah, look, unfortunately, in these studies, anyone who had an allergic reaction has been, in fact, stopped from having the study. So I'd like to tell you that they never do that. But I think sometimes prostaglandin allergy really is toxicity, and I'm not always entirely clear whether it's strictly an allergy, but they are currently prohibited from doing it. But it's, yeah, it's a good question.
Thank you, Michael. Wish you a good night's sleep. Thank you very much for joining us.
No problem.
We move on to the next topic, and it's a pleasure to invite Professor Shamira Pereira from the Singapore National Eye Center. He is also the co-head of bioengineering and devices at the Seri Institute and the deputy director of the MedTech Office Sing Health. He has co-authored a Golden Apple Award-winning free app module to teach and test cataract surgery with touch surgery, and won the Institute of Engineers Singapore prestigious engineering award in 2015. He has been conferred the American Academy of Ophthalmology and the Asia Pacific Academy of Ophthalmology Achievement Awards. He's a very famous invited lecturer and has over 140 review publications. And his research interests include medtech for glaucoma, cataract, surgical devices, and imaging. So over to you, Shamira. The floor is all yours. Thank you.
Thank you very much, Tanuj, for a very kind introduction. Can you see my screen?
Yes, please. Go ahead.
Thank you very much. And thank you to the organizers for a successful conference. I've enjoyed many of the talks that have gone on before already, and I think they should be congratulated for that. So I'll be speaking on the role of MIGS. This is a topic that's very close to my heart, and it really forms the backbone of a renaissance in glaucoma at the moment. These are my financial disclosures. I do speak for some of the MIGS companies, but none of them have had direct input on this talk specifically. So unless you've been a hermit, everyone knows about MIGS and its explosion onto the scene. There are new MIGS being created all the time, and there's a very exciting area for us to be involved in. They generally concentrate on the fact that these are minimally invasive glaucoma surgeries that offer a extremely low risk surgery, but with a tempered reward as well. Now, they have this promise of having this better quality of life, but as they're expensive, there's always going to be a trade-off against the poor cost effectiveness of them. The thing that I like specifically about them, I think that they're extremely elegant surgeries, and they're frequently combined with cataract surgery to give what we call phaco plus procedures. And they have very few of the sight-threatening complications of glaucoma surgery. And they're on the increase, they're very quick to perform. And I think as time goes on, the price will come down and they become much more competitive. And restrict my talk to the three main areas that they're involved in: the subconjunctival space, that's the PreserFlow and the Zen, the Schlemm's canal devices like the KDB, the trabectome, iStent, Hydrus, and ABIC, and the suprachoroidal devices. We had this SiPass, but of course it was taken off the market because of endothelial problems, and the iStent Supra, which is still not fully out yet. This is what the glaucoma surgery landscape in SNEC looks like present day. And you can see in this representation of what we need as far as the disease complexity is concerned and the stage of disease versus the acceptable target IOP. Phaco MIGS occupies a large area where the disease is not so complex or advanced, and you can tolerate a slightly higher IOP. Now, that area has been growing and growing in size since the emergence of MIGS in SNEC in 2015. And it's been growing at quite a rate, taking most of its work from the TRAB group. Of course, the indications are usually for mild to moderate glaucoma with open angles, but there are plenty of contraindications. And these are angle closure, neovascular, traumatic, malignant glaucoma, uveitic glaucoma, congenital glaucoma, and those with elevated episcleral venous pressures. Now, although these seems like quite a lot, there are some research areas embedded in those, and there are some specific off-label uses that we have used them in, but of course these are extremely rare. As you can imagine, we don't want to use them in the case of ocular hypertension and pre-parametric propionate glaucoma when there's no real vision loss. NTG also is difficult because it doesn't get the IOP that low sometimes, and you're really struggling to get it to that level, or you might need to have add drops as well. We have sometimes put them in when there are stents already in the eye, but then again, this is extremely rare. And those with previous incisional glaucoma surgery, if that means like a tube or a trab, you've got to be really thinking, what am I going to achieve and is it going to work? Angle closure in the eye is an interest of mine, and I have been putting these devices in angle closure because of research interest. So what I'll be trying to find out is what is the best correct patient for the best choice of MIGS. And of course, as with any surgery, you have to take in mind the life expectancy of the patient, the coexistent cataract. Is the patient symptomatic? Has there been any pattern of field loss that's worrying? And how uncontrolled is the glaucoma? And I'll be going through certain areas to see what are the advantages and limitations of these MIGS as far as safety, efficacy, quality of life, and cost effectiveness is concerned. So there's a little competitor matrix which just shows you what these devices are like. You have the TM MIGS. This is generally variable to put in. There are very little side effects that can occur, and generally they don't have any effect on subsequent glaucoma surgery. The efficacy is modest. The subconjunctival ones are a bit more efficacious, but of course you have to still have the same problems as you do with the TRAB as well. And then the suprachoroidal devices, which again have a variable efficacy, but now we know more about that particular area. We are seeing that some of them can be efficacious if we target that space correctly. We know there are several problems with drops, and when you're getting to the stage where you're using 2 and 3 drops, you are exacerbating the patient's quality of life because of dry eye that's been induced. And especially when you get to 3 and 4 drops, that's really becoming a problem. So I think that's a sweet spot. If you've got primary open-angle glaucoma with coexistent cataract and 2 drops, and it's relatively controlled, that's a good indication for most of the TM MIGS. We know that patients hate using drops because of the side effects. We know that in 50% of newly diagnosed primary open-angle glaucoma cases, they don't even use their drops correctly. And 50% of the prescribers are not even reaching the eye, and 25% of our patients only take drops prior to their exam visit. So if we could get the patients drop-free, that would really improve their quality of life and also glaucoma control. When we look at adding drops, in one study, when you add a third drop, it actually caused the IOP to increase in 21%. So it really wasn't effective at all. And the probability of IOP reduction of more than 20% after giving a anti-glaucoma, third anti-glaucoma medication is only 33%. So really quite unimpressive, really. When I was explaining about what's the sweet spot and explaining that that's that 2 medication zone, that's been shown to be proven by one study, which shows that having 2 iStent injects equivalates to latanoprost timolol combination. But as you know, that studies are telling us to go lower and lower with IOP. Our AGES study, which is one of our most important studies, which look at how low the pressure must go to prevent any field loss, says that you need to get a mean IOP of around about 12.3 to get no real visual field progression on average. And this simply cannot be achieved with TM MIGS. You can see where the MIGS fit in this graph of efficacy over time point. And they're in the middle here. They're better than the ALT, but not quite there towards steep sclerectomies, generally speaking. The other devices that do get to that level of being like a TRAB competitor are the Miniject and PreserFlow. This is Miniject is a into the suprachoroidal space device, and the PreserFlow is a subconjunctival device. And these are getting very impressive IPs, just like a TRAB. But of course, if they cost more, what real advantage are they giving? And if you consider that, well, you're sometimes getting the same problems that you can potentially get with a TRAB, like the infections and extrusions, then the need for needling as well is also a significant problem. Then what are we really doing for the patient? In one very interesting study of phacohydrous, it showed that actually if you chose to put that in as opposed to a phaco, you were able to achieve a 61% reduction in risk of further glaucoma intervention at 5-year time point. That's quite significant. And these are in eyes that didn't have very much glaucoma to start off with. So if it's worse glaucoma, then yes, they would really be benefiting that patient by keeping them out of having a more serious, potentially more complicated glaucoma intervention. 2/3 of the patients had a very mild IOP, very mild glaucoma at that point. When we stretch the limits and look at things like primary angle closure glaucoma, you can see whenever you go off piece like this, the results are not as good as the open angle cases. And you can see here that when you're doing angle closure eyes, you're really balancing the positive effect of removing a big lens in angle closure versus a limited effect of opening the angle up with a particular device in the trabecular meshwork. And you can see the results are not quite as good. And of course, worsening glaucoma does not favor MIGS at all. You really should be going for the cases with a TRAB or a tube in this case. Now, there are a lot of different MIGS, as you know, and there are some that are more milder and some can be used in more moderate glaucomas, and there are a few that we can use in the advanced glaucomas. But of course, you are balancing the safety aspect over the efficaciousness. Cost effectiveness is a difficult one because it's very healthcare system specific, and generally speaking, they have not been able to meet that in any of the studies that we've had a look at this in. And especially now, specifically for India, where you've got generic drugs which are very, very cheap, it's very difficult to recoup these healthcare costs unless you're going to recoup it in terms of saving patients off a bigger glaucoma surgery. And of course, they're not always safer than traditional surgeries. If you look at some of these studies of the MIGS in causing hyphema, hypotony, choroidal detachments, and malposition or stent obstruction, you can see that actually they're really a significant number in these particular surgeries, and probably equivalent to what you may see with trabeculectomies nowadays as well. So the real gain here is for people who are not doing trabeculectomies regularly. Are these for the non-glaucoma surgeons, the cataract surgeon who wants to do a little bit more for the patient? Well, this remains to be seen, because when you really want to get the pressure down, it seems like you need to go for a TRAB. In all these studies, when you look at the IOP reduction and the MED reduction, the TRAB has the advantage. And then you have to really consider the cost of these devices and the extra interventions that might be necessary in them to equivalate to a trabeculectomy. The only thing they might be having an advantage in is saving time. and for use by the less experienced surgeons, of course. Now, generally speaking, what I tend to say is that we're at the level of just the version 1s of these devices, and prices will drop with competition as things move on. And with reimbursement models being looked at as well, then there may be a move to including these more in our armamentarium. I've always said that the learning curve for MIGS is transferable. So when you start learning them, you can use the same skills on other MIGS as well, and you become much better at doing it across the board. But of course, there still is no shortcuts available for MIGS, and you really should stick to the rules. We have an increasing number of MIGS available, and it'd be unethical for all of us to learn these 16 different devices, for example. So in our center, I was given the task of learning how to do these devices and then rationalizing, picking one for the subcon space, one for the suprachoroidal space, and a few for the angle, so that we would have a range of devices that would have certain uses, but not that everybody would have to go through the same learning curve. Now, we're still not there with the RCTs and comparisons between MIGS, but hopefully as time goes on, we are getting data now out to the moderate term. So I hope this will improve in the longer term future. Thank you very much. I'm happy to accept any questions.
Thank you, Shamira. So just one question for you, Shamira. Like in India, we just had the release of the iStent, but the cost is nearing $2,000. So basically, we can't use it for our patients. So do you recommend that we can use AV internogoniectomy, the bang, or the trabeculotomy GAT procedures for our patients? Because these are low cost procedures. The rest of them, the implants are too expensive for us.
Yes, I mean, I think if you follow what's been happening in Eastern Europe, which has a similar kind of a model for healthcare, I'm surprised that these procedures that you talk about, the very low cost ones like GAT and the needle trabeculotomy, are not more popular. I think it requires a little bit of a leap of faith and a bit of surgical skill involved, but I think that you should temper the response that they get, remember, because they're not going to be that amazing IP lowering, but in terms of cost effectiveness, yeah, it's just the price of a Prolene suture.
Okay. Thank you, Shamira. Thank you very much for joining us. So over to Dr. Namrata Sharma.
It is my pleasure to introduce the next speaker, who actually doesn't need any introduction. Dr. Anthony Aldave. He's professor of ophthalmology at the Steen Eye Institute, UCLA Medical Center. He received his medical degree from University of Texas Medical Branch in Galveston. He performed his residency training in ophthalmology at Wills Eye Hospital, Thomas Jefferson University in Philadelphia, Pennsylvania. He completed a 2-year cornea, uveitis, and refractive surgery fellowship at the University of California. Presently a professor of ophthalmology, he holds the Walton Lee Chair in Cornea and Uveitis and is the chief of the Cornea and Uveitis Division and the director of the Cornea and Refractive Surgery Fellowship Program at Steen Eye Institute. He received numerous awards, including the Heed Ophthalmic Foundation Fellowship, the American Ophthalmological Society NAP Testimonial Fund Fellowship, the first Claes Dolman Society Award, and the Achievement Award, Secretariat and Senior Achievement Award from the American Academy of Ophthalmology. He has authored over 160 peer-reviewed scientific publications, has been invited to over 460 scientific presentations at local, national, and international meetings, and serves as a scientific reviewer for 20 ophthalmology and genetics journals. He also directs the Corneal Genetics Laboratory at the Steen Eye Institute that focuses on the molecular genetics of the corneal dystrophies. He is going to be talking about the future of the treatment for the Fuchs endothelial corneal dystrophy, molecular and cell-based therapies. Can we have the recording, please?
Hello, I'd like to thank the meeting organizers for the invitation to participate in the 55th RPC Annual Foundation Day celebrations. My name is Anthony Aldave. I'm a professor of ophthalmology at the Steen Eye Institute in Los Angeles. By way of disclosure, I have no financial interests that are relevant to this presentation. So over the last 5 years, DMAC has become the procedure of choice, of course, for managing conditions such as Fuchs corneal dystrophy. However, as you saw in that video, the surgery is not always straightforward. It has a steep learning curve, especially for surgeons who have not learned DSAC prior to learning DMAC surgery. So this increased difficulty in performing DMAC surgery is evidenced by the rate of primary graft failure and early regraft, which, as we can see in this graph, is 3 times higher for DMAC, shown here in the green line, as compared to PK, shown here in the blue line. Therefore, I think it's clear that there's a need to continue to develop simpler, more easily reproducible approaches to the management of Fuchs corneal dystrophy, both here in the United States, as well as to address the primary limitations to the management of corneal endothelial failure, including Fuchs, globally, by changing the one donor, one recipient paradigm, and to develop alternative approaches to managing corneal endothelial failure that does not require donor corneal tissue. So we'll talk about some of these approaches. Personalized therapeutic approaches first, gene therapy and pharmacotherapy, as well as universal therapeutic approaches in the form of induction of endothelial cell proliferation and migration and cultured allogenic human corneal endothelial cell transplantation. So let's start with genetic therapy. We know that majority of patients with Fuchs dystrophy have a trinucleotide repeat expansion in the TCF4 gene. It's about, I think, 70% overall will have this expansion. We can see here in this table that if you look at patients with Fuchs who have this expansion, 79% of them will have more than 50 repeats, as compared to only 3% of control individuals that have more than 50 repeats. So how does this trinucleotide repeat expansion cause disease? Well, it's thought that it results in an accumulation of pathogenic expanded repeat RNA as RNA foci in the corneal endothelial cells, as you can see depicted here. So Vinod Mutha and colleagues at UT Southwestern have reported the utility of using the CRISPR-Cas9 system to target this trinucleotide repeat expansion and reduce the intracellular repeat RNA in corneal endothelial cells in Fuchs corneal dystrophy. So the investigators studied the impact of stable long-term expression of Cas9 and repeat targeting guide RNAs on mutant repeat RNA by quantifying the RNA nuclear foci using FISH, as we see depicted here, in a corneal endothelial cell line established using endothelial cells from a patient with Fuchs dystrophy. They found a significant reduction in foci in cells expressing Cas9 and the repeat targeting guide RNAs relative to the untreated cells. We can see that in these two graphs. The percentage of cells with RNA foci decreased from 59% before treatment to only 6% after, and the number of foci per 100 cells decreased from 73 to 7.5. They saw no decrease in the foci in cells transfected with a control guide RNA. So therefore, the investigators' data suggests that the CRISPR-Cas9 system can effectively reduce repeat RNA nuclear foci in patient-derived endothelial cells and represents a viable gene therapy approach for one of the most commonly inherited age-related degenerative ocular disorders. So let's talk about pharmacotherapeutic approaches to treatment of Fuchs corneal dystrophy. Now, this is not Fuchs. This is congenital hereditary endothelial dystrophy, which you know is another endothelial dystrophy, and unlike Fuchs, presents with congenital corneal edema. Demonstrating an autosomal recessive inheritance pattern, SHED is associated with over 80 mutations in the SLC411 gene. While homozygous and compound heterozygous SLC411 mutations are associated with SHED, there have been 15 presumed pathogenic heterozygous SLC411 mutations identified associated with a subtype of Fuchs called Fuchs4. So what does this protein do, SLC411? It's a membrane transport protein on the endothelial cell basolateral surface. It's an important component of the endothelial cell pump. Our group and others have demonstrated that many of the identified mutations in SLC411 result in protein misfolding, which then causes the protein to be sequestered in the endoplasmic reticulum, and thus it doesn't get to the plasma membrane where it has to be to work. A small-scale drug screen showed that glafenine, which is a disused non-steroidal, was able to move some of these SLC411 mutants from the endoplasmic reticulum to the cell surface, suggesting that other non-steroidals might also have therapeutic potential. So Joe Casey and colleagues investigated whether other commercially available topical ophthalmic NSAIDs could correct the cell surface trafficking of the SLC411 proteins. What they found was that 5 of the 6 ophthalmic non-steroidals tested for the ability to correct the trafficking defect of these mutants significantly increased the cell surface abundance of this G709E, which is one of the mutants that's been associated with Fuchs endothelial corneal dystrophy. So we can see each of these green bars with an asterisk above it indicates that treatment significantly increased the cell surface trafficking of the mutant. Now, the demonstration, though, that these topically applied non-steroidals can increase cell surface trafficking of these endoplasmic reticulum retained mutants really is not of therapeutic benefit unless the rescued mutants retain function. So using a water flux assay as a measure of transport activity, the investigators demonstrated that this G709E mutant exhibited large, significant increases in water flux activity upon treatment with napafanac, depicted here in the red bar, and diclofenac, depicted here in the blue bar, as compared to the untreated control depicted here in the yellow bar. Thus, we see that both napafanac and diclofenac restored the SLC411 mutant water flux activity to a level that's actually similar to that of the wild type. Dr. Ramappa and colleagues at LV Prasad are currently conducting a clinical trial of topically applied nonsteroidals for treatment of CHED. They're screening SLC411 in children with CHED, and if they're found to have one of the mutations associated with mislocalization of the encoded protein, are treating one eye with topical napafanac and using the untreated eye as the control. So far, they've enrolled 30 patients and expect to complete enrollment in approximately 1 year. If the results are favorable, we will then have a commercially available treatment for the management of some children with CHED and some older adults with Fuchs. So now let's shift gears to universal therapeutic approaches. These would be relevant for any patient really with endothelial cell dysfunction from Fuchs dystrophy. And the first is the induction of endothelial cell proliferation and migration. And there's 3 different approaches here. One, decimase stripping only. The second, Rho kinase pathway inhibition. And the third, fibroblast growth factor 1 or FGF1 supplementation. So we'll start with DSO. And you're probably familiar with this technique, which involves the removal of the central diseased endothelial cells plus the decimase membrane. And that allows a removal of the contact inhibition that's normally present, thus allowing the peripheral endothelial cells that are relatively healthy to migrate centrally and cover the area of exposed stroma, and with that resolve the corneal edema. So here we see an image of a patient who's had DSO performed, probably about a 3 or 4 millimeter diameter area where a decimase has been removed. And obviously by the fact that the cornea is clear, it's evidence that the peripheral endothelial cells were able to migrate in and resolve the overlying stromal edema. This is a video of the technique that was provided to me from Dr. Greg Maloney. You'll notice it looks like a capsulorhexis is being performed, but this is not the anterior capsule. This is decimase. Again, using here these microforceps to remove the central 4 millimeters of decimase membrane. It's done with viscoelastic in the anterior chamber. And so that is, of course, removed at the end of the procedure. So the whole procedure itself would probably take no more than 5 minutes. We're still trying to identify which patients really are ideal candidates for this approach. But certainly we're finding that given the right patient profile, this is an effective therapy for Fuchs that, of course, does not require donor corneal tissue. Now, let's talk about Rho kinase pathway inhibition. Rho kinase is said to promote endothelial cell migration and adhesion. That's Rho kinase inhibition, I should say. increases endothelial cell proliferative potential, and maintains the endothelial cell phenotype during ex vivo expansion. It has been used both topically and also intracameral, topically as far as monotherapy and combined with DSO, and intracameral combined with injection of ex vivo expanded endothelial cells. This is a paper looking at the use of Rho kinase inhibition together with DSO from Greg Maloney and his colleagues. And they evaluate the utility of using a Rho kinase inhibitor following DSO. They reported the results of 23 eyes of 23 patients who underwent a 4-millimeter DSO. Rapacidil was applied topically from day 1 post-op 6 times a day until the cornea cleared. Cases that had a relapse of edema were allowed to restart Rapacidil at 2 drops a day for another 2 weeks. 22 of the 23 eyes achieved corneal clearance at a mean of about 4.1 weeks. One patient, however, did fail to clear and underwent a DMAC 12 weeks after the DSO was performed. 39% of the patients experienced a relapse of edema on stopping Rapacidil, with clearance again upon recommencing it. Now, Marianne and Frank Price evaluated the utility of using topical Rho kinase inhibitor in the treatment of Fuchs, not combined with DSO, but just as monotherapy in a patient with early Fuchs dystrophy. They enrolled 29 subjects with symptomatic Fuchs and randomized them to either use Notarcidil or placebo eye drops once a day for 3 months. Compared with placebo, Notarcidil produced significant reduction in central corneal thickness at 1 month. We see a decrease of 20 microns in central corneal thickness at a month and a decrease of 26 microns at 3 months. They also noticed a significant improvement in the scotopic corrected distance visual acuity at 3 months in those who were treated. So this, I think, study gives us initial data to support the potential of a topical Rho kinase inhibitor to reduce central corneal edema and improve visual acuity in patients with early symptomatic Fuchs. Let's talk a little bit about FGF1 supplementation. FGF1 stimulates endothelial cell proliferation and migration and protects endothelial cells from stress and injury. Treatment approaches here would be an intracameral injection as a monotherapy in patients with early stage Fuchs and in patients with moderate to severe Fuchs combined with DSO. These images were provided to me by TrueFellow Therapeutics from an animal study demonstrating a more rapid coverage of the area of exposed stroma following DSO in the eyes treated with engineered FGF1, seen here in the bottom row, as compared to the eyes that were not treated, the control eyes as seen here on the top row. So this animal data served as a basis for 2 human clinical trials conducted by the company. The Intrepid trial was a prospective multi-center study to determine the safety and efficacy of engineered FGF1 on regeneration of endothelial cells in patients with endothelial cell dysfunction or loss. 22 patients were enrolled. They received 4 intracameral injections of FGF1 or placebo at 7-day intervals. No drug-related adverse events were reported, and we await the outcomes of the study. The STORM trial is a prospective multi-center study to determine the safety and efficacy of engineered FGF1 on regeneration and migration of endothelial cells in patients undergoing DSO. So in this case, the 40 patients who were enrolled underwent DSO, either received none, 1, or 5 intracameral injections of FGF1 after DSO. This study is still ongoing, so we await the report of the primary and secondary outcome measures. And then finally, let's talk a bit about cultured allogenic human corneal endothelial cells. You're probably all familiar with the pioneering work that Dr. Shigeru Kinoshita and colleagues have performed in this area. This is from an article they published in the journal Ophthalmology last year on 5-year outcomes of the first 11 patients receiving intracameral injection of engineered ex vivo expanded endothelial cells. So these are slit lamp images and pachymetry images from one of the 11 patients. Here, this is taken pre-injection, 3 years, and then 5 years after cell injection therapy. You'll note here, looking at corneal thickness for all patients, that at 5 years after injection of these endothelial cells, central corneal thickness was within the normal range in 10 of the 11 treated eyes. These are specular microscopy images of the central cornea in each of the 11 patients at 5 years after surgery. You'll note that they did not remove the central descemet membrane, and thus we can still see guttae in the patients who had Fuchs. The primary endpoint of this study was an endothelial cell density of more than 500 cells per square millimeter at 5 years after surgery. And that was obtained in 10 of the 11 treated eyes at 5 years after surgery. Of those 10 eyes, 8 had endothelial cell density actually greater than 1,000 cells per square millimeter at 5 years after surgery, and 2 had more than 2,000 cells per square millimeter at 5 years after surgery. So Arion Biotech is a US-based biotech startup. It acquired the rights to Dr. Kinoshida's cultured human corneal cell injection therapy and is currently preparing an NDA for submission to Japan's equivalent of the FDA and is preparing to initiate clinical trial in the US later this year or early next. So in summary, while endothelial keratoplasty has greatly improved the outcomes of our management of Fuchs dystrophy, there is still a need both domestically here in the US and internationally to develop treatment approaches that do not require advanced surgical training and fresh cadaveric donor corneal tissue. Novel molecular treatment modalities for Fuchs are really based on our insights into the corneal endothelial cell physiology and the pathogenesis of Fuchs. The discovery that majority of Fuchs is related to a TCF4 trinucleotide repeat expansion has led to the advent of CRISPR-Cas9 targeted genome editing to edit out this trinucleotide repeat. The identification of a subtype of Fuchs being associated with mislocalization of the SLC411 protein has led to clinical trial ongoing, looking at topical nonsteroidal therapy for patients with these mutations. And also insights into the fact that endothelial cells are arrested at the G1 phase of the cell cycle, but can actually be brought out of that arrest, has led to the use of topical Rho kinase inhibitors, both clinically and in trial, as well as FGF1 supplementation in ongoing clinical studies. So evolving surgical treatment modalities for Fuchs have changed traditional paradigms in corneal transplantation. Traditional paradigm that one donor cornea is needed for one recipient is not necessarily the case anymore in the era of ex vivo expansion of allogenic endothelial cells. And the thought that we need donor corneal tissue to address corneal endothelial dysfunction is not necessarily the case now with some initial results from descemet stripping only. So we are seeing an evolution of these treatment modalities for Fuchs that allow us now a stepwise customized approach to treatment. When genetic testing reveals a patient may be a candidate for gene therapy or topical pharmacotherapy, we may soon in the future be able to offer them targeted genome editing in the form of CRISPR-Cas9 delivery to the endothelial cells, or topical nonsteroidal therapy. In a patient who has mild central stromal edema, but no peripheral edema and good peripheral endothelial cell density, we can look at using topical Rho kinase inhibition, intracameral FGF1 supplementation, or potentially descemet stripping only. And in the patient with moderate to severe central stromal edema and peripheral stromal edema, in addition to DMAC, we may soon have the ability to offer that patient injection of ex vivo expanded endothelial cells. I want to thank all of you very much for your attention. And if you'd like a copy of this presentation, you can take a picture of this QR code with your phone. Again, thank you very much.
Looking very good. नजरें झुकाए हुई थी ना ऊपर ही देख रहा था. He's good. Okay, you can start the next session. Have the people joined, admin?
Yes, sir. Our speakers have joined.
Okay.
Hello, sir. Good evening, sir.
Very good evening. Good evening to all of you. Thank you for joining us.
Thank you. Thank you for giving the wonderful opportunity for all of us.
So I would like to invite Dr. Tushar Agrawal, who's going to moderate the upcoming session. Dr. Tushar Agrawal, the virtual dais is all yours.
Yes. Welcome to this next session, A to Z of cataract surgery. It will be chaired by Professor Ityaz, Chief of RP Center, Professor S.K. Kokar, Professor Radhika Tandon, Professor Namrata Sharma, and Professor Rajesh Sinha. I invite Professor Rajesh Sinha to come on the dais. And we'll quickly get on to this session. We are running a little late. So the first speaker is Dr. M.S. Ravindra, who will be speaking on SICS, a savior for challenging cataracts.
Good evening, respected chairpersons, Dr. Jeevan Yal and his colleagues, moderator Dr. Tushar and panelists. I wish to present a couple of videos here. One of them is a hypermature cataract, which is of Morgagnian type, and a topical anesthesia sitting temporarily on the steep axis. I've made an incision, which is done by about 2.8 millimeter. Is the video running?
Yes, sir.
Fine. So I've filled the chamber with HPMC, and I made a small prick in the anterior chamber, and you can see it's so, in spite of the anterior chamber being filled with HPMC, you can see the milk coming out of the capsular bag. What I'm trying to do is I'm rotating the nucleus within the capsular bag, go a little fast. This is to decompress the capsular bag as much as possible before I do the next rhexis. The tunnel is slightly enlarged to about 5 millimeters. Because it's a very large, thick lens, nucleus, I'm enlarging the internal tunnel with the 2.8 keratome, aspirating as much of cortex as it's possible. Then I'll do the rotation a little more, and then I enlarge the rhexis using a Van As. It's a double rhexis now, and it's about 5.5 millimeter, 6 millimeter, adequate sized CCC. And repeated injections of viscoelastic is essential. Before I do anything else, I prolapse the nucleus into the anterior chamber. You can see the zonules are not stretched or pulled at all. The nucleus remains in the center of the visual axis. And this is a very hard nucleus which I can't bisect with a cannula. I'm using the help of a cystotome. The cystotome is mounted on a 2cc syringe, lower lock syringe, which is filled with HPMC, and throughout the procedure, I'm infusing HPMC into the anterior chamber to separate the nucleus from the endothelium. Protection of endothelium is very dicey, and it has to be taken care so that nucleus doesn't move here and there. And the visco is continuously, as you can see here, is being infused so that it separates the nuclear pieces from the endothelium. So now it's small enough for me to remove it through the tunnel that I've made without stretching the tunnel. It's very important not to stretch the tunnel throughout, because this tunnel has to collapse and close the anterior chamber waterproof at the end of the surgery. Now the second half is also removed. The cortex is sticky, very sticky to the capsular bag, in spite of several attempts. As you can see there, a lot of cortical material is stuck on the capsule. This is a very unusual presentation. Normally, so much of cortex is not stuck on the capsular bag. This is a single tunnel. There is no side port, so I'll have to use a reverse Simcoe to aspirate the cortex, which is in the tunnel area. Now, a lens, which is multifocal, is implanted into the capsular bag, and it's very important to do a good biometry. Immersion biometry gives excellent results, and that's positioned nicely. Remove all the viscoelastic, and this tunnel produces about half to 0.75 diopter of astigmatism. And at the end of the surgery, you don't even have to stromal hydrate. You just form the chamber to normal physiological levels. You don't have to over inflate the anterior chamber, and that will be the end of the surgery. Is that video visible? Is another video playing there?
Yes.
Fine. This is a case of a posterior subcapsular cataract. looks like posterior capsular cataract. I very carefully do a rhexis. I'll go a little faster. What is most important here, I would like to stress on, even in a case like this, which looks threateningly posterior capsular, you can do a very gentle hydrodissection. This is you can see the capsular bag getting separated from the subcapsular opacity, and segmentally, the fluid just goes across. You can see the entire posterior capsule is exposed there, and the subcapsular opacity is separated from there. It's a very low pressure technique. It needs very little fluidics, and I'm rotating the nucleus. These two are taboos in a closed chamber surgery, but this is an open chamber surgery at this point of time. I've kept the tunnel open. Chamber is shallow, and I'm not pressurizing the posterior capsule posteriorly. Now I can bisect the nucleus very comfortably. It's a very soft nucleus. I can bisect it with the 25 gauge cannula, and I can remove this, and then because it's a low, you can see here the posterior capsule is exposed there. There's no tear there, it's exposed, and the fluidics is very low, and the fluid that I need to complete the surgery is only about 20 to 30 milliliters of pressure. The pressure inside the eye is atmospheric at this time. You can see step by step I can remove the cortex completely, and now I can put a lens inside, and that's a different kind of management of posterior subcapsular or posterior capsular opacity, where you're free to do a hydrodissection, capsular separating, as well as the rotation of the nucleus, which are taboos in high pressure technique.
Sorry to interrupt, sir. We have 60 more seconds to summarize.
Fine. I think that's it. I have a couple more videos, but I would like to stop it here, stressing the fact that MSICS is a wonderful technique. We can perform any kind of complex surgeries using this methodology. The advantages are it's a low pressure, low flow technique. The pressure inside the anterior chamber is extremely low throughout the procedure, and endothelial protection is maximum in this case because we're not going to use so many instruments inside the eye, and it's a simple and less stressful for the surgeon, and any complex case can be managed very elegantly with this technique. Thank you.
Thank you very much, Dr. Ravindra. Next, I'd like to invite Dr. Harshul Tak, who will be speaking on magical Maligan ring.
Thank you so much. At the outset, I'd like to thank Professor Titial sir, Namrata ma'am, Rajesh sir, and entire RPC team for your kind invitation. Am I audible there?
Yes, please.
Yes, sir, loud and clear.
Okay, so I'll be showing few cases which are done with the help of Maligan ring. We all know that whenever we have a situation of small pupil, it becomes very difficult to manage. But with the availability of this device, this magical Maligan ring, the small pupil surgery has become a child's play in most of the surgeons' hand. So this is the injector which with this Maligan ring comes. So it comes in two sizes, 6.25 and 7 millimeter opening it gives. So this is the original version of the Maligan ring. So the leading scroll, it goes and engages the pupillary margin. And from the side port, you put a Puglin's hook to guide the lateral scrolls, two lateral scrolls, which when open, you can most of the time can engage both these scrolls at the same time. And then just push the proximal scroll and this ring is in place. So you can see once this ring is in place, it lies in the pupillary plane and there is no tenting up of the iris tissue, and it maintains the opening of the pupil throughout the surgery, and you can take off the cataract. And so either you can use the same injector to take this ring out, or you can use this is the Puglin's hook, which I have inverted and just pulling this ring out. So once you hold this scroll, it comes out from the main wound. So sometimes it may happen that you're not able to engage the lateral scrolls, but you can put OVD again and go from side port and engage the lateral scrolls. So it's very flexible and it's very tissue friendly. You can easily insert the engage the pupillary margin. So many times you need to use the two instruments to disengage the scrolls like this. And again, you can just go from another side port and engage the pupillary margin to get the proper opening. So this is the case. This case had IFIS. You can see that the patient had black cataract. And so nowadays, it's a routine to use the Maligan ring in the first place whenever the patient has a history of using the tamsulosin or any other drug and pupil is not dilating. So you can see this is the newer version, 2.0 version of the Maligan ring, which goes through 2 mm incision. So here again, you see the leading scroll, it goes, engages lateral scrolls, engages the pupillary margin. So once this ring is in place, so this is a black cataract. It maintains the pupillary dilatation throughout the surgery, and you can see this is the last pieces which has been taken off. And once the IOL is put in play in the capsular bag, you can nicely enlarge the capsular rhexis to get the desired size. And see, once I disengage the ring and I start hydrating the wounds, you realize the iris is tending towards the incisions. I'd like to show one more case. This is a case. Okay. In which the penetrating keratoplasty was done few years back. And this was the white cataract with posterior synechia and small pupil. So here I'm inserting irrigation cannula in through the side port. And before I stain, I go through side port and using the tubulance hook, I release all the synechias before putting any OVD so that I can get good staining of the anterior capsule. So once I stain anterior capsule, go ahead and put some OVD beneath the iris. This is another way you can implant this, insert this Maligan ring. This is the cartridge, the IOL, so you can reuse the Maligan ring. You can see here the lateral scrolls they come. It's little tricky here because of this broad PI which is there. So many times you need to use two hands to engage the proximal scrolls, as I'm doing here. But once this ring is in place, you can see we get a good opening here. And this is a hard cataract. Finish off the cortical irrigation aspiration. Put the IOL, and you can again enlarge the rhexis of desired size, adequate size, before taking off this ring. So this is another advantage of using these devices, that the lenses which we are using nowadays, they require good proper size of the rhexis, which can be achieved if we have adequate pupillary dilatation. So you should be very careful while disengaging the ring that you don't damage the iris tissue.
Dr. Harshul, 60 more seconds to go.
Yeah, I'm done. So here goes out the ring, and you can hydro stitch incisions. So by using this magical device, I think any complicated surgery which is having small pupil can be made very simple. Thank you very much for giving this wonderful opportunity.
Thank you, Dr. Harshul Tak. Next, we have Dr. Priya Narang, who will be speaking on a very complex topic, traumatic cataract and iris repair. I invite Dr. Narang to please begin.
Good evening, everybody. Am I audible here right now?
Yes, ma'am, loud and clear.
Yes.
At the outset, let me start by thanking Dr. Jeevan Tityal sir for this wonderful opportunity, and Dr. Namrata and Dr. Rajesh Sinha and everybody there at the RP Center for having me here. Thank you so much. So I begin my talk with the topic that I usually love it, and I keep on handling such cases in my private practice. So I will be covering up the traumatic cataract along with iris repair, and today I will be just talking about the two-fold technique. Exactly what is a two-fold technique and how we go ahead. Now, this is something which is real massive. What you see on the left side is the undilated pupil of the patient, and you can have a look at this, and on the right side, it's a dilated state. So now these are the real challenging cases when they come up to you in your OR. So you need a multiple approach when handling these cases. So I just go ahead with my method of how I go ahead with this. This is a two-fold technique which we had described. Actually, in a two-fold technique, the first technique comprises of an iridodialysis repair, which can be any method that you want to use. It can be a non-appositional by Dr. Snyder, or it can be a sewing machine or a modified sewing machine, whatever. And the second technique is that, whenever you do a iris repair, you always have a retraction of the iris tissue out there. So you need to reconstruct and center the pupil, and that is where we use a pupil-centric method, which my favorite is, again, a single pass flow-through pupilloplasty procedure. So I'll be just showing you a combination of these two procedures, and I just have one video to show here. So as you see in this case, this is a case of a traumatic cataract, and you can see a massive iridodialysis out there. So I go ahead with retracting of the iris tissue before we do the cataract removal, and the cataract extraction is done as usual. Foldable intraocular lens is placed inside the bag. So now the real challenge, it comes right now. This is the modified sewing machine technique. It's a bit modified than the original sewing machine, which has been described by Dr. Steve Safran and also by Dr. Ravi from Vijayawada. So in this modified sewing machine, you take these multiple loops, and of the suture, they are passed. So instead of cutting all the loops and tying the adjacent sutures to each other, we just take one end of the suture, which is passed through all the loops, and then we just tie this, and you are done with the procedure of iridodialysis repair. So this is a modified sewing machine technique. Now, this is what I tried to emulate in my patient. Now, this is, I'm just threading the 26 gauge needle with the suture. This is a 9-0 polypropylene suture, which is taken. So once threaded, you just leave a little bit of suture at the end of the 26 gauge needle for the sewing machine method. Peritomy, as you see, is done, and you have cauterized and you made a scleral groove, a partial thickness kind of scleral groove, because this is from where the needle, your 26 gauge needle, will be coming out. You can also use a 27 or a 30 gauge needle if you are comfortable with whatever you have in your OR at that point of time. So what you actually now see here is that I'm just pulling up the suture, and I get this loop. You have to engage the, you have to titrate the amount of iris tissue that you are going to imbibe in your needle. So once you know that how much amount of iris tissue is there and it is an ideal form, you just go ahead and come out from the scleral wall, and you get this loop. And now when you are going inside, you have to be very careful. You have to prevent the slippage of these loops. When I tried doing this technique, I learned it a hard way. When I had one slippage, I had a slippage of one of the loops. So what now I do is that, I just take an iris spatula and I pass that spatula through all these loops so that, it does not tend to slip back inside the eye. So this is what you keep on doing throughout the entire area of iridodialysis, whether it's a 90-degree, 180-degree, whatever amount. This technique, I think it works beautifully for an iridodialysis repair method. The only thing, teaching point that I would like to focus in this is the imbibement of the amount of iris tissue. Especially what happens is that when you have long-standing cases, the iris tissue, it does not behave the way you want it to behave. If it's a fresh case, it still behaves the way you want it. But if it's an old case which has come up to you, the iris tissue, it actually does not behave. You have to keep on holding that iris tissue, and you have to be very careful handling. You can see there is some amount of bleeding hyphema which has occurred in this case. No doubt it resolves within next 2 to 3 days, but still you have to be careful about it because iris tissue is also inflamed in these cases. So having the one of the suture, and I'm now just passing through all the loops, and it's a comparatively faster procedure as compared to the conventional one, because you don't have to keep on taking sutures with the adjacent neck. It's just one shot and you are done with that. So you take this and you are done, and you just bury it into the scleral groove. But now, as I said, you have to be very careful of how much iris tissue you are taking. You can see that now there is correctopia. That is, you see a retraction of the, although the base is repaired, there is a pulling of the iris tissue on one side. So now the short method to do this is to construct the pupil. You can decide the amount of centration that you need in this case, and then you can go ahead with doing the procedure. My choice is single pass flow through, but anyway, because it's simple, fast, easy, but you can use any other method that you want to use, and whatever is good in your hands. So having pulled the sutures from both the sides, you can just see how beautifully it slides back inside, and you get a very good centered pupil here in this case. And this is the post-op image of this case. Looks brilliant, I think, and the patient came back to 6/9 vision in the post-operative period. So I think I just end up my talk. We're running short of time. Thank you so much for your attention.
Thank you. Thank you so much, Dr. Priya, for your talk. Next, Dr. Meenu Mathan will be speaking on pre-existing posterior capsular tears.
Good evening, everyone. Am I audible?
Yes, yes, yes.
Yeah. So let me thank Dr. Titial, Dr. Namrata Madam, and Dr. Rajesh Sinha for this opportunity. So I'll go on to the topic, saving the day in pre-existing PC tear. So no financial interest in this. So let's start with one of the first case. This is a posterior polar cataract, and you can obviously see that there is a end-to-end open posterior capsule here. You can see the two lines which are extending from the side. He had some minor trauma and came up. He's not a very young person, but he's in the 30s, late 30s. So a very well-centered rhexis is a very important prerequisite here. And now see this technique. So I am aspirating the cortex and then going around the nucleus, which is soft, but then still there is a nucleus. So here the vacuum is kept very low and adequate power to cut through, making sure you don't go through and through to the posterior capsule. So you create a gutter all around the nucleus, and the nucleus is picked up. So the nucleus is gone. So you don't get a nucleus drop here. Now comes the epinucleus and the cortex. So epinucleus, my preferred technique is to use mechanical separation. You can always do a viscodissection also, but then this chopper of mine, a 1.75 millimeter long blunt tip chopper, it helps me go around the equator and free the epinucleus all around and remove the epinucleus mechanically partially. So once one half is removed, I can pull up the other half and lift it up, no rotation, but lift it up into the anterior chamber and remove it piecemeal. So here the vacuum and the flow rates are kept very low, and the bottle height is also low, but it should not cause surge. That is the setting which one should have. And once the epinucleus is gone, we can see the open capsule, still no aspiration close to the open PC, and replace always with viscoelastic, and then I go in with bimanual irrigation aspiration. Here again, the aspiration flow rate is very low, and aspiration happens away from the area of PC rupture. So you catch the cortex, lift it up, be far away from the PC end, and now again to change hands, I again put in viscoelastic and plug the PC end area. Here the good thing will be to use viscoat, no financial interest in that, but then it plugs the PC end area and avoids vitreous prolapse. If you get vitreous prolapse, one needs to do a vitrectomy, but then here we can easily go ahead without getting a vitreous prolapse by controlled aspiration, holding the cortex, lift it up, move away from the area of posterior capsule opening, and then aspirate gently with low aspiration flow rate. And see here the bag is all emptied now. Again, I fill the capsular bag and the anterior chamber with the sodium hyaluronate now, not viscot, and then take out the irrigation so that the chamber never shallows or chamber never deepens. Now I place my 3-piece foldable IOL into the sulcus. This is an AMO one. You can choose whichever one, but then because it is going into the sulcus, we can, if your rhexis is small enough and it is centered well, we can always cap.
Patrick, क्या वीडियो?
Have we lost connection from?
I think there's a break in the connection.
Yes, Dr. Meenu, will you share again?
No. I think it's paused.
Can he go to the next speaker in the meantime?
Should we go to the next speaker, sir?
Yeah.
Okay.
I think we'll go to the next talk. It is a pleasure to invite Dr. Gaurav Dutra to give his talk on jet polishing for PC plaques the safer way.
Thank you, Dr. Namrata, and congratulations to the RPC team on the Founders Day. And thank you, Tityal sir, for organizing such a mega event. And
Meenu is back.
okay, so I'll wait.
I got cut off. Sorry.
I'll wait.
Meenu, can you continue from where you left?
Yeah. Where did it get cut off? Did I finish the case or?
Yes, you're putting the 3-piece lens. Yeah.
Okay. Fine. I'll show one more case. There is another case going on, so that I'll finish with that. Okay. Sorry about that. Sure. I'll share the screen right now. So I'm seeing, na?
Yes.
Yeah. So this is another case. So this is again a blunt trauma young man and comes with an open PC like this. So it's a very soft cataracts in the 20s, but then still it's a wide open posterior capsule. So here again, I should stress that the rhexis is very, very important. We should have a 5 close to 5 or even slightly less than 5 so that you can capture the optic very well and very well centered. Here again, you notice I'm doing a very gentle, very segmental, few bolus of hydrodelineation, and even that is not required because it's a very soft cataract. And I remove the central, whatever nucleus is there. Again, I go ahead with my mechanical separation of the endonucleus and the epinucleus. So this is what I like. I use this from 3 different directions, the main incision and the 2 side ports. And now I go in with my coaxial IA and start separating from the equator, just retaining the epinucleus there and gradually finishing off quadrant by quadrant epinucleus from the periphery and reaching towards the center to very late. And gradually it takes quite a long time because it is epinucleus, but then we need to keep the chamber filled up and gradually and slowly aspirate. Once the epinucleus part is taken out, sometimes you may get vitreous. See, at that point, you will have to stop and do an antivitreum. See, no, now the irrigation is not taken out. Fill up with, again, viscode and go ahead with your bimanual irrigation and aspirate the cortex. Again, the cortex aspiration happens away from your area of posterior capsule rupture, and the flow rate and aspiration, the aspiration has to be very low so that it doesn't pull anything away from your aspiration port. Catch it, hold it, and pull it out. Now again, I go in with again viscode, fill up that area, plug that area completely, and change hands and aspirate the cortex. So I'll move fast. This is the filling up of sodium hyaluronate now into the anterior chamber. See the rhexis size, which is well centered and adequate sized for your 3-piece IOL, goes into the sulcus. And once in the sulcus, we rotate. And now you can see the rhexis margin underneath, which is very, very well smaller than the optic. Now tuck one side of the optic underneath the rhexis margin, and the other one is gently and slowly tucked in underneath the other side also. So here you get a very well centered lens and no vitreous prolapse.
Yeah,
so
Dr.
the last one,
second
short one. Yeah. This is a very short one. This is a post vitrectomy case. And in few weeks, it came with a total cataract like this. So there is silicone oil inside. And the good thing is that there is no cortex to the nucleus to aspirate. So you can just aspirate bimanual or Simcoe. And at one point of time, you will see a posterior capsule opening and see the silicone oil popping out. At that point, don't take the irrigation out. Fill up with visco as just we saw and finish off the aspiration. And in this kind of cases, after a few weeks of time, you can see that the opening is fibrosed. And so it is very rigid. You need not take this risk of placing a 3-piece lens into the bag, but just showing that a 3-piece lens can also be placed into the capsular bag without this PC opening extending because of the fibrosis which we have because we waited for a few weeks' time. Thank you for the opportunity. Thank you very much.
Thank you, Dr. Meenu, for those lovely cases. May I now request Gaurav to give his talk on jet polishing for PC plaques, the safer way.
Thank you, Dr. Namrata. I'll just share my screen. So as I said, congratulations to all the RPC team for a wonderful program and for inviting me, and Tityal sir, thanks for considering me. I have been working on, improvising bimanual handpieces and, improvising techniques for polishing plaques. And we obviously, all of us, tend to use our own ways of polishing. You have polishers of various kinds. Now, a few years back, I used to polish plaques with, of course, polishers and sandblasted cannulas. And then I realized that, a very nice way is to just go from the main port with a stream of fluid, which is continuously running. Not from the side port, because then the flow is not going to be significant, but from the main port with the posterior lip depressed, you'll have a nice flow of fluid. And you can actually, wash away these plaques without touching the PC, without even occasionally touching it. And then there's no risk of breaking the PC, because you're actually using a high flow system where the fluid is constantly flowing and, kind of in a very safe way, washing them away. So then we improvised, and we developed these bimanual handpieces, which were both sandblasted and polished, and matched to the incision size. So they are 22 gauge, and they are both sandblasted in a very fine way. And of course, while you can do conventional IA also very nicely with that, but you minimize the chamber leaks from the calibrated side ports. But you can also go and use these both these handpieces for polishing. Now, obviously, since they are sandblasted, you can polish, and you can use the aspiration one for trying to remove these occasional plaques that you might find. But when they are resistant to polishing, and when you might feel that you can actually catch the PC and break it, then you can just go from the main port. And now using a dual mechanism, so it's running fluid continuously from the main port, plus it's sandblasted, so you can gently do a polish. And this is, I like to call this as the jet polishing. And of course, these are special handpieces designed for me, and which also have this fine sandblasting. And you can see that how easily and in a very safe way you can actually go quite boldly. Unless you want to poke the PC, you will not break it. And the PC almost always, because the fluid is constantly flowing, you don't end up catching the PC or kind of damaging it in any way. And very effectively you can manage to kind of loosen up all these resistant plaques, and almost everything can be removed except those which are really stuck and need to be peeled. So you can actually loosen this, and at the end you can just go back from the side port and quickly aspirate it and leave behind a very, very clean PC. Going on, you can sometimes have challenging situations where sometimes, in spite of your best efforts at removing the cortex, sometimes there will be some resistant stuff which gets stuck and left behind. And then, of course, you want to do something about it. You don't want to leave a PC which is going to need a yak capsulotomy very soon. So once you have removed much of the cortex, you can see here that there is this matter which is stuck, and I'm trying to kind of peel it from the PC, and I'm catching the PC with this aspiration port. So very easy way, as I told you, just go in with this jet polishing kind of a system, and use sandblasted, infusion cannulas, and go from the main port. If you go from the side port, you will not be able to achieve this unless you open the main port as well, because then you have to set up a high flow system. So since now I'm going from the side port, but I'm opening the main port to allow egress of fluid, so that I set up a high flow system. So you can see here that I'm now going from the other side, because I have only one main port. So now I'm going with the infusion from the other side port, but opening the main port and loosened everything. It takes only a few seconds, and it's a very, very safe way. And you can see now that once I'm in, I'll be able to remove all this in a moment. Like, it all becomes so easy to remove. And right up till the equator, if you have very resistant cortex as well, you can actually remove it very, very safely and easily. Now here's another situation where we are left behind with PC plaques, and at the end of the aspiration, and it's going to be very unsafe to peel off the remaining plaques from the PC with a polisher. So again, now, rather than risk, here you can see that I'm trying to peel it from the PC with a very gentle aspiration, yet you always stand the risk, especially in these vitrectomized eyes, the PC will break. It's very fragile. So you can see that this is one way of doing it, but the better way would be what I just showed you. And we can quickly switch hands and go in from the main port and do a quick irrigation from the main port and loosen up everything. You can see there, and in moments, this all becomes nice and loose. So you can see that how easily it is getting separated, and there is no trauma or risk of breaking the PC at all. And it sets up a very, very nice situation after that, because it's all loose. Now, I think we've got the message. So let me take you to something else. Now, once you've all done all that and you still have stuff remaining, then you can do a very gentle, I like to call this as nibbling the PC. So you can see that with very low vacuum and very good foot pedal control, I'm just vacuum polishing the PC. Sometimes you need to do this because you may leave behind stuff which will not come with any kind of polishing or any kind of jet washes. And last but not the least, I'm going to the last video where it's a vitrectomized eye with a subluxated cataract, and we are going to use capsular hooks and a very, very hard cataract. And it's a one-eyed patient who's delayed his surgery by almost 7-8 years and now needs the surgery. So we managed to remove the cataract, but we are left behind with a dense PC plaque. And you can see that how thick a layer, and it's a bag which is fragile because there's zonular dehiscence. The bag was moving completely. And these are very dense plaques, and I'm going to try and aspirate them. And you have to do it obviously very patiently. We have a slightly smallish rhexis. So I'll be over in 20 seconds now. So once you try to attempt removing these plaques, you know, obviously you can see that I can obviously increase the zonular dehiscence. It's a vitrectomized eye. Breaking the PC is very, very easy here. So after trying it for one quadrant, I decided that I can use my usual technique of doing a jet polish. And I go in from the main port. And you can see there's a lot of stuff in the equator as well. And once you set up a high flow system and go from the main port, and you have a polished irrigation handpiece like this, which is designed for me by Epsilon, and I have no financial interest, but you can go and nicely loosen up almost everything, not only on the PC, but also behind the anterior capsular rim. So you can just go snug to the anterior capsular rim and do a wash. And see on the other side now, I'm keeping the main port open, doing an irrigation, loosening up everything. And let me take you to the end where I can now aspirate everything very easily. It's all come out in a moment, and that leaves me only with this central plaque, which obviously will not get polished, but I've loosened the edge with my jet polishing. And now I can just hold it with my microrhexis forceps and peel this plaque. And at the end, it looks nice. Here I'm peeling the plaque. So you have to be very patient and use safe techniques, and you can get away with a lot. And here I'm able to peel it off completely and give a very nice clear PC. So with that, I'll stop here. I think I was able to peel it off completely, and just let me take you to the end. Yes, thank you so much.
Thank you. Thank you, Dr. Gaurav, for presenting a very wonderful technique. We move on to the next speaker, and that is Dr. Kumar Doctor, and he'll be talking about demystifying zonular support.
Good evening, everybody, and I would like to at the onset thank Professor Tityal, the whole team, including Rajesh Sinha and Professor Namrata. Thank you very much for this opportunity. It's a real big honor for me. I'm just sharing this video which got an award at the ACR.
The zonules are a series of fine fibers that connect the crystalline lens to the ciliary body. The function of the zonules is to hold the lens in place. The zonular fibers arise from the pars plana
Paucity of time, I'm going to go a little forward and start
and posterior, finally inserting into the lens capsule. The signs of panzonular weakness are well described in literature. The present video aims to demonstrate and discuss the signs of selective anterior zonular weakness, namely the capsular wrinkles, and selective posterior zonular weakness, namely the capsular flutter and the PC radial sign and their management.
Let's demystify the zonular weakness and sing some jingles for the capsular wrinkles. Let's demystify the zonular weakness and sing some jingles for the capsular wrinkles. What if only the anterior zonules are weak? Then my earphones you are maybe less so.
During capsular rhexis, notice the wrinkles of the anterior capsule beyond the rhexis margin. These take place because the anterior zonules are weak and there is no countertraction. A cohesive OVD may be used to prevent rhexis runoff. In such cases, one has to take care during cortical aspiration, and such bags may need an additional support with an endocapsular ring.
But if only the anteriors on yours are weak, then my dear friends, you all may be left shell-shocked when you perform the all-important capsular exit. There is attraction, no counter-attraction. The anterior capsule will show the wrinkles, and she will try hard to extend and just run off. If you're not careful, she will disappear, and to the equator she will quickly take off. What if the posteriors on your limb become slack? Then surely the PC will bulge forward and become slack. Once the cortex is up, you may see some fine lines. Please do remember this. All you PC radial side.
During cortical aspiration, note the movement of the posterior capsule and its flowability with the cortex. As the cortex is stripped from the posterior capsule, there is neither any movement of the posterior capsule nor a flutter, thereby indicating strong posterior zonules. If the posterior zonules are weak, note how the posterior capsule follows the aspiration probe as the cortex is stripped off. Once the cortex is stripped off, note the fluttering of the lax posterior capsule indicating weak posterior zonular support. Yet another case of a posterior capsule flutter. Another case of selective weak posterior zonular apparatus. Note the fluttering of the posterior capsule upon the introduction of the IA cannula. When the cannula exits the eye, note the forward bulging of the lax posterior capsule along with the appearance of fine radial lines, which is the PC radial sign. These disappear as the capsular bag is inflated with an OVD. Here we postulate on removal of the irrigating cannula, the deflation of the capsular bag causing the posterior capsule to bulge forwards in areas where the posterior zonules are weak, while it is held back in place in the areas of intact posterior zonules, which gives rise to the radial folds or lines which we call the PC radial sign. We further postulate that such bags, when re-inflated with an OVD, the PC radial sign disappears. Such bags should always be strengthened by placing an endocapsular ring for better stability for premium IOLs.
If you encounter this, please do not fear. Gently inflate the bag with an OVD. Stabilize the PC, dropping the anchor by placing in the bag a sturdy CTR. What if all the T's on your limbs become weak? Then surely the surgical scenario does get complete. It's the right time to stay calm and not panic, because the lens is a sinking Titanic.
In cases of panzonular weakness, where there is a subluxation present, one can perform a femto-assisted rhexis with a fragmentation of the lens. The capsular hooks will support the subluxated area till the fornix of the lens. This is followed by safe eco-emulsification in the bag.
So this is just the sign, and this is the last 1 minute.
In such cases, the novel PC radial sign and the floppiness of the posterior capsule causing it to follow the aspiration probe during cortex removal are signs of selective posterior zonular weakness. This floppy posterior capsule should always be stabilized with an endocapsular ring. Iridofacodonesis, a crescent sign, and irregular anterior chamber depth are signs of panzonular weakness. Capsular hooks, Sionis, and Emmett segment should be used to perform a safe in-the-bag phacoemulsification followed by an IOL implantation in such cases. Thank you for your attention.
Thank you.
Brilliant.
Thank you, Kumar Doctor. I think that was a wonderful award-winning video which just said it all. I would now request Dr. Suhas Haldipurkar to give his talk on triumphs and tribulations of managing subluxated cataract. We will take the questions which are related to the talks after we finish the presentations.
All the talks.
Dr. Suhas, you need to unmute yourself. You are on mute.
Good evening. Thank you so much, Dr. Titial and Dr. Namrata and the entire team for giving me this opportunity. I'll be speaking on managing subluxated cataracts. The management of subluxated cataracts has always been a challenge, but in the last decade or so, there have been a lot of new devices and a lot of new techniques that have come, and naturally because of which management has become more efficient. But there always remains a doubt in our mind as to what will be the late post-op consequences. Because, we have started seeing now most of our cases done 10 years back, coming back with teno suture disintegration, where the lens back complex sometimes tends to hang loose, or sometimes with the flimsiest of a trauma, the entire lens back complex sometimes dislocates into the anterior chamber or dislocates posteriorly because of progressive zonulopathy. So it becomes all the more, bigger responsibility on us when we manage these cases to look at what will be the late post-op. And a loose back could be because of developmental, degenerative, and traumatic. And naturally, we are happy with a traumatic subluxated cataract because the rest of the zonules are always strong. So managing it becomes difficult. A safe surgery will be a cataract removal, like a safe removal of the cataractous lens, long-term stability of the capsular bag, and if possible, safe implantation. And of course, in the event of loss of the bag, we would definitely like to fix it properly. The management strategy obviously would be delay the surgery as long as the vision is correctable with glasses or contact lenses. And if you have to intervene, try and preserve the bag as much as possible so that the lens implantation can be done in the bag. And in the absence of capsular bag, explore the best option for the appropriate lens location. And when you manage evaluation of location of defect, degree of zonular loss are very important, and the presence or absence of vitreous in the AC or presence or absence of phacodonesis definitely tells you how safe or difficult that thing is going to be. So when it comes to strategy for reducing zonular stress, careful and complete separation of lens material and cortex from the capsular bag is very important before the emulsification. And during surgery, always pull the nuclear material towards and not away from the weakened zonules. And a capsular tension ring inserted prior to lens removal facilitates phacoemulsification, but it makes cortex aspiration difficult. The iris hooks that we use for small pupil management can also be used here, and also, of course, the capsular hooks. Now, in this case, this is a case of extreme loss of zonules, where the bag is literally hanging on few zonules on either side. Now, these are the cases where, one, you have to puncture it with a sharp tip. You have to fill the eye with either viscoadaptive substance or dispersive viscoelastic to help you create your rhexis. And if at any stage the rhexis is not progressing well, you may bring in your hooks, fix the bag, and complete the rhexis. Now, in this case, because of good stability, because of good dispersive viscoelastic, the rhexis is possible. Always try and make a big one, but you somehow end up making a smaller. In this case, I would definitely like to make a bigger one. Now, the next challenge here is to find a space between the rhexis margin and the nucleus mass. Especially in a loose bag, it is difficult to find one. So you may have to sometimes use a sharp needle to create some space, because unless you do enough and more of a hydrodissection and loosen the bag and loosen the nucleus within, it is always very difficult. And then the second challenge after you've done rhexis is to get your first hook into this bag. In such a bag which is loose and hanging, you somehow have to use a spatula to tent on the rhexis margin and find some space and get your first hook in. And once the first hook in, and relatively the bag is stable, getting the second and the third and subsequent hooks is not difficult. At times in such extreme cases, you may have to use more than 4 hooks, sometimes even 6 or 7. In this case, I'm using 5 of them. And once you have it nicely stabilized, then doing things become relatively easy. Now in this case, once these hooks are in place, now unfortunately, this is a very relatively hard nucleus. You have your hydrodissection done well. The bag and the nucleus are separated well. I use a blunt chopper to go behind the nucleus, beyond the nucleus, and try and break it, and try and pick the endonuclear part as much as possible outside. Because if you do emulsification inside, there's always a fear that you may catch the posterior capsule.
Dr. Suhas, 60 more seconds to go.
Okay. And once the bag is, once the nucleus is removed, you put endocapsular ring. And in this case, I'm planning to use an ASIA anchor to fix the bag and use the zigzag technique, because nino suture has got a bent needle on the opposite side. Because the zonular damage was more, I'm using 2 ASIA anchors on either side. And once you fix on either side with this technique, you fill the bag again with the viscoelastic, and getting the lens inside is a little tricky. So you have to handle it very carefully. Sometimes it takes a little time. With 2 instruments, you can always gradually get your trailing haptic inside, and then wash out the viscoelastic, try and constrict the pupil, and the lens is quite stable. And because you have used 2-sided support and nino suture, these eyes can do well in a long time as well. Thank you so much.
Thank you, sir, for your pearls on managing subluxated cataract. Next, we have Dr. Abhay Savada, who will be talking on cataract surgery in silicone oil-filled eyes.
Thank you, and thank you for accommodating me. And I'm jumping the cube. I appreciate. Cataract surgery in silicone oil-filled eyes, or where it's removed. I think, as a cataract surgeon, has understood the challenges of removal of the cataract, low parameters, low IOP, low wattle height, low flow rate, and so on. I think that's fine, but still, one of the challenges is the posterior capsule plaque that the silicone oil produces. That's because of the epithelial mesenchymal transformation, and they become an integral part of the posterior capsule. So I'm showing you 2 cases where I learned hard way the strategy of how to deal with this. This is the first one. We removed the cataract successfully and putting the 3-piece IOL, and I prefer 3-piece over single piece in these elongated eyes and big bags. And then I have to now remove the silicone oil and then address the plaque. So I'm just removing the silicone oil. Actually, I'm not removing, my retinal colleague is removing it, but silicone oil is removed after the IOL implantation. And then we need to address the posterior capsule plaque. Now that the lens is already in, a better way would be to perform with the highest cut rates and moderate vacuum to produce plaque. Now, it's okay in a children or a clear capsule, this works very well, but in a plaque and fibrotic capsule, it doesn't always work. The uncontrolled tear developed into that vitrectomized capsulectomy eye. Now, if this is such a big uncontrolled eye, I think we should not put the lens in the bag. We should do that. So in trying to get this haptics from the bag into the ciliary sulcus, we were struggling here, and we were dreading what will happen here, what will happen. And the manipulation or maneuvers to bring it out was faulty, and therefore the IOL sinks. So what we learned that time is that we should have a retinal colleague available, even if it's not an OT, when you do this such eyes. And therefore, we had to call him from the other floor, and he managed to get the IOL out, and the IOL then was removed because of the high myopia. We left it ophakic, but you have a choice of intrascleral fixation, glued IOL, or Yamani technique, or iris fixated IOL, or iris scroll, whatever, but this eye was fixed. So that's something we didn't like it. So we questioned our strategy. So when we had the next time a patient with silicone eye filled, this time what we did, we changed our strategy. Remember, we did a lens first and vitrectomy, silicone oil removal later on. This time, our colleague removed the silicone oil first, and then we decided to address the posterior capsule plaque because they are not amenable to YAG capsulotomy. So this is the same eye in a red glow, and we are trying to produce a capsulorhexis, and you can see how fibrotic this is. And sometimes you may have to use scissors, Greisaber scissors or small scissors, but this worked well. Remember to use the peripheral part of the posterior capsulorhexis plaque as a support. So the plaque is very extensive, but we just aiming a small rhexis, 2 or 3 millimeter at the most, so that the remaining posterior capsule, which is very strong plaque, will support the IOL in the bag or otherwise. So we are trying to limit our posterior capsulorhexis to a small size, and then we are able to do that. We need to go very slowly, and as I say, the use of scissors sometimes become necessary, but here we are lucky that we could achieve that. And once that has happened, it's not difficult to place a lens in the bag, and you can see that that works quite well. And this is the post-operative picture of that eye, and that looks fine. So what did we learn? What I learned at that time was that needs a planned strategy, first of all, and if possible, because if you have to remove the oil, we better get it done with retinal colleague, then he should stay there. He should not leave that room until we are done. So remove the oil first. PCCC, from my experience, is preferred over capsulectomy. If you have a very good machine and a very good control, you can do sometimes, but it's not the machine, it's the fibrotic plaque that doesn't always produce a smooth, strong capsulectomy margin. So I prefer PCCC, but remove the oil first and produce the rhexis, and then you implant, because you could see you have to explant it out later on. So that's one, and prefer 3-piece IOL. So this is one which is already been removed. The oil has been removed, and this is a typical scenario. And we produce a small rhexis in that plaque once again. Because the oil was removed, we didn't have to do that. But otherwise now, we do that as a routine. So we do not touch the capsule with the retractor or with the PCCC forceps until the oil is removed. And then this is not difficult. It goes in the bag, and you can consider single piece in that case. So I think this is what I need to share, emphasizing how to manage the plaques. And you have the same plaque with the radiation plaques, with the tumor treated or sometimes chemotherapy, younger patients. So have the strategy, very clarity in your mind. How are you going to address well before you start the cataract removal? So thank you for your patient hearing.
Thank you, sir, for wonderful tips that you gave regarding managing such a case, which is definitely a very tricky scenario.
Thank you.
Thank you so much. And after that
Thank you.
wonderful talk, we go ahead with the next speaker, Dr. Savin Silvan Pereira. And the topic is where we are today on CME and Indian perspective.
Very good evening, everyone. And on the outset, I would like to thank Professor Jeevan Titial, Rajesh Sinha, and Namrata Sharma ma'am for this opportunity. The topic today I'll be taking is, where are we today on cystoid macular edema? I hope my voice is clear and my slides are visible.
So your voice is clear, slide is not yet shared, sir.
Okay. So you can see, are my slides visible now?
They're just coming up. Yes, they're visible now, and you're very loud and clear. Yeah, we can hear you well. Thank you.
Yeah. So where we are today on cystoid macular edema and Indian perspective, and this is something which is very nice topic, because we come to know that cataract surgery was one of the most common surgeries in the world, just recently taken over by hair transplant surgery. And with over 82 lakh surgeries being done all over the country, we have a large number of patients. And if you see the number of cystoid macular edema, it's about 2%, but angiographic, it's about 20%. Now, with India becoming the diabetes capital of the world, we have around 47% of the patients without pre-existing DR and maybe 55% with pre-existing DR. So it's a lot of patients. And we all know the pathophysiology of diabetic retinopathy and how does CME also come in these patients. And it's mainly the breakdown of the blood retinal barrier because of the prostaglandins which are released post-surgery, which is the most common cause. Either if there's a PCR, it may be accelerated, but these are the most important factors. And what we should understand is it is one of the important causes which causes reduction in vision, be it our cataract surgery or vitreoretinal surgery. And when we say CME, we definitely know that the angiographic CME being more common, while the clinical CME, which is diagnosed on your slit lamp biomicroscopy, is less, but it's more visually debilitating. So when we talk about CME, if it occurs within 4 months, yes, it's the acute onset, and greater than that, it's the late onset, and 6 months is chronic. And majority of the patients are going to be presenting with decrease in visual acuity, loss of contrast, color vision, distorted images. And we should always look for retinal thickening, look for vitritis in the optic nerve head, and we should see how fast are these symptoms appearing after surgery. And that's very important. Are there any pre-existing diseases, ocular conditions, systemic conditions? Is there any complications in surgery? Now, regarding diabetes, as I said, that India is becoming the diabetic capital of the world, we should know that the incidence of CME is much, much higher in patients with diabetes and in hypertension. Also, in patients who had previous retinal vein occlusions, glaucoma, uveitis, we should know that these are all pre-existing factors which is going to advance your CME. And also, we should never forget the intraoperative complications. Coming to diabetes, as I said, that when we talk about diabetes, there's already a microangiopathy which is going on. The blood retinal barrier is already compromised, and any surgery is going to cause more and more of fluid leak into the intracellular spaces, causing balloon degeneration and CME. And the incidence of CME is about 2.5 times more in Indian patients, especially with diabetes. So this, we need to keep it in mind. And whether the patient has diabetic retinopathy or not, the incidence is similar. So it's not say that, okay, a person has just mild NPDR or no diabetic changes. The risk of being diabetic itself is going to cause CME in your patients. Coming to the diagnosis of CME, we have a great new systems which are there. Fluorescent angiography is now taking the back seat with more and more people doing OCT, and classification and follow-up being a non-contact, non-invasive technique is much more easier. Regarding autofluorescence, a lot of research and studies have been published, and you can see the classic Henle pattern over there. Now, one of these slides which I would like to share is the differentiation between diabetic macular edema and cystoid macular edema. And we should remember that we should be able to classify which one is DME and which one is CME, because the treatment is very different. And many a time they can even coexist. So this needs to be very, very careful. And we should always see that where are the pre-existing cases of diabetic macular edema, is it central involving or not, and treat the patient accordingly. Coming to the management, I would say prevention is better than cure, but here prophylaxis is much more important, and we should try to prevent it from occurring in the first place. And if you see, yes, we have the medical therapy, the surgical treatment. If we come to the prophylaxis, NSAIDs is definitely the first line of management for the prevention of CME. And we should always try considering prophylaxis, especially in patients who are diabetic, uveitic, who have pre-existing risk factors, and it definitely helps out. I would like to talk a little bit about this molecule, nepafenac. And the reason why I'm talking about this molecule of nepafenac is a very interesting factor, is that it is a prodrug which gets converted to amphenac, which is activated by the vascular rich tissues of the eye. So basically the choroid, which prostaglandins, is the real reason why amphenac is produced. So basically it's target specific nepafenac, where it gets converted into amphenac in the tissues of the eye. And we should remember that we always want a very good drug which is universally accepted, at the same time which has good compliance, and once a day dosing is something which is really, really very important. And
Dr. Savio, we have 60 seconds left. Thank you, sir.
Yes, yes. So one of the reasons I'm talking about this drug is if we look at the aqueous concentration of the drugs, we can see that amphenac is the maximum nepafenac, and the ability for it to stop COX-2 is the maximum. When we talk about India, we have different strata of patients. Compliance is a big issue. And definitely there's a lack of standard treatment protocols, and availability and cost is a very important factor. There's a lot of generous, which are spurious drugs also which are available, which we need to be careful. And 90% of patients do admit for poor compliance in the post-operative medications in cataract surgery. So this is something which is very important. So just to summarize, I would like to say that, yes, you need to take care of your patients. You may be the best cataract surgeon in the world, but CME is something that we should know and we should try to prevent, and prophylaxis is always better than cure. So thank you very much. And once again, thank you for this wonderful opportunity. I hope I stuck to time and finished it as per the schedule.
Thank you. Thank you.
Thank
It
you
was
very much,
wonderful.
Dr. Pereira. Thank you.
Thank you.
Next, we'd like to invite Dr. Mohan Rajan, who will be speaking on rock hard cataracts.
Dr. Mohan, could you please unmute yourself and start your video? Sir, I think Dr. Mohan he's logged in, but he's away from his PC. So can we invite the next speaker and we'll ask Dr. Mohan?
So meanwhile, we can move to the next speaker, Dr. Arun Jain, who will be speaking on monovision with enhanced monofocal IOLs.
All right.
Good evening.
So I'll be sharing my screen. So is it visible?
Sir, visible, sir.
1 second. I went to last.
It's the last slide.
Yeah. Okay. So at the very outset, I'd like to thank Dr. Tityal, Dr. Namrata, Dr. Rajesh, Dr. Tushar, and Dr. Radhika for giving me this opportunity. So today I'm going to share my experience with the monovision with enhanced monofocal IOLs. And as we know, this iHance is an enhanced monofocal IOL with a different design, which is a extended depth of focus with the characteristic, as we all know, it is designed to enhance intermediate vision. And there is a continuous power gradient from periphery to center of the optic. It is created by tweaking the higher order asphericity, what is called modified aspheric anterior surface, and it provides an effective add of around 0.5 diopter at central 2 millimeter of intermediate vision. And also, we are all aware of this fact that the benefit of EDOF IOLs is it gives us combined advantage of multifocal and monofocal IOLs in terms of improved intermediate vision as well as less of spectacle dependency. And it also preserves the quality of life as good as in monofocal, and there are minimal photic phenomenon. And this is one study which has compared these three IOLs on the same platform, like monofocal, enhanced monofocal, and sort of symphony IOL, which is meant for good intermediate vision. And this study compared these three IOLs, and as we can see from this graph, that all IOLs give good distant vision, but at intermediate vision, Symphony is better than IHANS, and of course, no question, it's better than Technis. And but with the uncorrected near visual acuity, Symphony is far better than the enhanced monofocal, but far better than Technis IOL, as we understand. And this is the same thing to show in a bar diagram how many patients achieve distant good acuity with these three IOLs. Basically, these enhanced monofocal were designed to cover the fallacies in the biometry at the distance, so that even if there is around 0.5 diopter fallacy in biometry, that will be covered by these enhanced monofocal. But of late, people have started using it for intermediate vision also. And if you see in this bar diagram, none of them more than 3 log, less than 3 log acuity at near with the Technis, but almost 28% with Symphony achieved less than 0.0 log mar visual acuity at the near. So further, this study said that contrast was similar in all these three IOL, but it was slightly better in Technis, of course, understandable, as well as halos and glare were worse in Symphony because it is a diffractive type of EDOF, and spectral independence are also more with Symphony as compared to IHANS because it has a nearly EDOF of around 1.5 diopter. Study concluded that IHANS was not inferior to Symphony as regards to intermediate distal visual outcome and spectacle independence, and there was a lower subjective perception of halos and glare with this IHANS IOL. And as you can see in this defocus diagram, at 1 diopter defocus, Symphony and IHANS are almost equal, but at 1.5 diopter defocus, the Symphony does better than the IHANS. So these are the recent study in last 1 or 2 years, which has compared Technis with IHANS. And all these studies says that contrast is similar to the monofocal IOL, and defocus curve is to the tune of 1 to 1.5. Some studies says once up to 4 diopter. I don't know how did they do that. I have to catch hold of the study. It is published in IGO, and glare and halo were similar to the monofocal IOL. So the advantage of IHANS IOL is better intermediate visual acuity, more spectacle independence for intermediate distance, and similar distance visual acuity and similar contrast sensitivity and similar rates of glare and halo. So can we expand the spectrum of presbyopia correction by this IOL? As we know, IHANS IOL increases the intermediate vision also, and doing a pseudophakic microvenovision, can we use this as for the management of presbyopia? So let us see. So we did a sample size in 20 patients where we targeted the emetropia in one eye and micromonovision. We targeted 0.75 to 1.5 diopter myopia in the other eye. And this is one patient. You can see in one eye we have targeted the I am not able to see targeted emetropia. In the other eye we have targeted around 0.75 diopter of myopia. This is the DOF of the right eye and left eye. But once we do a defocus curve, this is on the eye trace. You can see with this defocus curve, this is the target emmetropia, target reflection in one eye, this is in the other eye, and this is the combined defocus of the two eye, and we get a binocularly the DO increased to 1.8 diopter with increased spectrum from 0 to 1.8 diopter. And we also did the manual DOF also, and manual binocular defocus curve was closely matching the eye trace. And if you see, manual defocus curve is always wider than the digital eye trace defocus curve, and you have to choose a IOL with such a power so where this downward trend of the defocus curve overlap with the downward of the other, so that the functional vision is above the 50% of this defocus curve. So if they overlap at midway, this much of functional vision you get, and you get a very good defocus curve and very good vision, intermediate vision. And so this patient needed no glasses for distance and intermediate vision. He required near glasses only for reading newspaper, books, and subtitles on the television. And there was no halos and glare. So this is coming to the
Sorry to interrupt, sir. Last 30 seconds, please.
Yeah.
Thank you.
Another minute. I'll just finish it. So another patient, similarly, we targeted myopia in one eye. So this is the defocus curve on the eye trace, and compared with the manual defocus curve. And again, patient didn't need near work. He could do without the glasses, and there were no halos and this thing. So we found from this study that distant vision in all patients were very good, and there was no need of glasses. Intermediate vision, most of the patient was satisfied, no need of glasses for operating mobile in 90% of the patient, and there was no requirement of glasses for routine work. And for near vision, most of the patient required glasses for reading newspaper or watching television, especially for reading subtitles in 65% of the patient, and 35% of the patient were spectacle independent for near work. And defocus curve was good from plus 0.5 to minus 2 diopter, almost a range of 2.5 diopter, and there was no glare or halos except for in 2 patients who had mild intermittent, causing no difficulty in daily life. So
sorry to interrupt, Dr. Arun. Can we summarize, please?
So it extends the range of focus and may provide spectral independence at all distances with minimal or no effect on visual acuity like glares and halos. Thank you so much.
Yes, we'll have the next. Thank you very much, Dr. Arun Jain. And we'll have the next talk by Dr. Mohan Rajan on rock hard cataracts.
Are you able to see my screen, Tushar?
Yes, yes.
Okay, let me at the outset thank Professor Titiyal, Namrata, Rajesh Sinha, and the entire RPC team. The RPC team is akin to the Indian cricket team, always energetic, dynamic, and always the winner. And it's always a pleasure and honor to be here in the RPC Foundation Day and present my experience on the rock hard cataracts. You see this cataract is a piece of granite inside the eye. And if you look at this cataracts, the first one pearl is rock hard cataracts. Good preoperative assessment is very necessary. Specular microscopy, grading of the nucleus, pupillary dilatation is very important. The age of the patient is also very important for us to understand these cataracts. If the cornea is sick, probably think of alternative methods of cataract removal like ECC or SICS. And these are the various challenges in hard-drawn cataracts. The challenge to phacosurgeons, the most important is very high phaco power is being used. And because of that, increase in the corneal edema and postoperative corneal decompensation, PCR, nucleus drop. Combine the technology with the technique in supra-hard cataracts. Technology is available with you. All machines are working very well. Stellaris, Ozil, the Centurion, whatever it is, and the Signature Pro. The technique is vertical chop using a sharp chopper. And these are the various machines which are available with us as well. And I'm sure it is available everywhere. And these are the divide and conquer and the stop and chop technique. If you do this, then probably you can end up in a corneal burn. You know the consequences of corneal burn. And we also have a corneal edema like this. The corneal edema can take about a month or two to completely disappear or become clear. But the problem is when there's corneal edema, there can be associated cystoid macular edema as well as the fibrin reaction, something like the toxic anterior segment syndrome. So number 2 pearl will be peribulbar, parabulbar anesthesia. Please understand this surgical time will be a little longer in these patients. So always use peribulbar anesthesia. If the patient is a little high myopia, more than 24 millimeters, then I would probably use a parabulbar subtenon anesthesia. Then go for always what do you call it, Rexis and a trypan blue, which is again very important for you to understand this ball game. So again, don't be very aggressive in your hydrodissection, and because there can be a nucleus drop, and unfortunately this thing is not playing. And again, do a high phaco power. That is number 5, 80 to 100% for trenching. This is very, very important, because if you use low phaco power, you will push the nucleus. And every time you push the nucleus, you will damage the zonules or weaken the zonules, which are already a little weak in hard-bound cataracts. There's another problem. So always make a very, deep trench, and also may use a very high phaco power. Adequate tip exposure is very, very important. When you use adequate tip exposure is again very important, because for you to bury the tip into the nucleus. Again, a vertical chop, a karate chop. I use the sharp chopper, which is Mohan Rajan chopper, which is made by Appaswamy Associates. I don't have any financial interest. Chop through and through and make it into smaller pieces as well. The length of the chopper is 1.5 to 2 millimeter. You have 1.5, 1.75, 2 millimeter, very sharp tip. There's absolutely no damage to the posterior capsule. You can see it's a 1.5 millimeter, 1.75 millimeter, and 2 millimeter, which is used for the black cataracts as well. It will be a little scary to see this chopper under the microscope, but please take it from me, because these cataracts are all very thick cataracts, as thick as about 4 millimeter or 5 millimeter. So you will not penetrate or touch the posterior capsule, because these choppers are very, very safe as well. Just to show you that trypan blue, why trypan blue, even if it's a cataract is not mature, because you know exactly where your rexis margin is and where to chop. Make a small trench there, and you can chop. You can see here, bury the tip and chop all the way down. You can see chopper works like magic, which means that you need to use your left hand. You have to be ambidextrous. Your left hand has to work more than the right hand. And once you chop vertically down and do the lateral separation, you can see the posterior nuclear plate, which is the toughest part of the nucleus, open up very nicely. And you can see the posterior capsule through and through. So once you do that into smaller pieces, once you take the first piece out, taking the first piece out is a little difficult. And then create a space in the posterior chamber, which is again very, very important. And then now and then put viscoat into the anterior chamber to make sure that the corneal endothelium is well protected. So chopping all the way down, and without chopping is very important. Without doing the chopping, don't try to bring this nucleus up. Okay, making sure that you chop all the way down and making sure that you see the posterior capsule. These are parameters I use on a Stellaris mission. Whatever mission, whether you want to use a peristaltic mission or a Venturi system or Ozil or ellipse or whatever it is, whatever you're comfortable with. Only thing is you need to have a high vacuum, and also very, very important is to have this pulse, the hyperpulse and the occlusion micropulse or whatever is available in your mission. This is a black cataract, just to make sure I make a little more deeper trench and then go in and chop. Again, I use a 2 millimeter chopper, as I told you, because the black cataracts, the cataract is very, very thick. This is called the cataract of Niagara. What I showed earlier is cataract of rubra, and you can see the parameters, how I'm chopping it. Once I chop it into smaller pieces, then I use the hyperpulse. So again, the hyperpulse, the hyperpulse thing is wherein during the on time, it cuts the cataract. During the off time, it cools the tip and sucks the cataract into the tip. So this hyperpulse or micropulse makes the life very, very easy. You can see here how I'm using the hyperpulse. Once I'm chopping the cataract into 2 halves and then go in and attack each of these halves and make it into multiple small pieces, and then go ahead and use the hyperpulse. And so that in a peristaltic mission, always when you are removing the last piece of the nucleus, reduce the parameters, reduce the aspiration flow rate, reduce the vacuum, because
Rajan sir, 60 more seconds to go.
Yes,
sir.
Yes. Always introduce viscoat through the side port. This takes a little more time, but spend that time because it's very important. Viscoat, I don't have any financial interest, any disposable viscoelastic. Viscoat through the side port is very, very important for you to understand this ball game. So these are the various viscoelastics that are available to us. The Disco Vis the Hyalon 5, the Viscoat, which is very, very important for you to protect the corneal endothelium. These are the clear corneas post-op day one. In all these cataracts, consistently you can deliver. If you have access to femto, phaco, or catalyst, that is the which I have, makes very life easy in rock-out cataracts, because already the capsulorhexis is there, whatever size you want. Then the pre-chopped cataract is there, the pre-chopped nucleus is there, and the amount of phaco energy which is delivered or which is used is only 1/3 of the regular one. So the top 10 for rock-out cataracts: good preoperative assessment, peribulbar or parabulbar anesthesia, rhexis with trypan blue, minimal hydrodissection, high phaco power, expose the tip, vertical chop or karate chopping using sharp chopper, and hyperpulse or micropulse or the cold phaco technology, viscoat through the side port, and also femto if you have access to. Quick Chop Express becomes very easy, effective, enjoyable experience for both the patient and the surgeon. Thank you, RPC, for the wonderful opportunity and the patient attention as well.
Thank you, Dr. Rajan. And now I invite Professor Jeevan Titial, Chief of RP Center, who will be speaking on panoptics and his experience with the new generation trifocals.
Thank you, Tushar. Indeed, it's been a great evening for us. I'd like to thank all the participants who have joined us live today, and audience sitting in the hall, all the speakers and panelists and the chairpersons. I'm going to talk about actually our experience on newer generation trifocals. We all know intraocular lenses modified not only the vision in the life of a person also, and multifocality is a desire for everybody. Especially we had bifocal design which came in the early 80s. Subsequently, we had refractive designs with its own problems. Then later we had a diffractive designs which are better than a refractive, but they also had halos and glare. Now we have trifocal lenses, which is supposed to give a better vision for all the ranges, as well as decrease the problem associated. So these trifocal lenses would have 3 distinct focal points, one for distance, one for near, and the intermediate area, which is so important in today's working life. And along with that, it should improve the visual quality in terms of decreasing the halos and glare and improving the quality of vision in these cases. That is mainly because increasing the light transmissions from these lenses and improving the contrast sensitivity in these cases. What about Alcon panoptic lenses, which actually gives a better light transmission amongst all the trifocal lenses we have today? It gives 88% light transmission. And it has the enlightened technology, basically looking for improving the intermediate vision because of change in the focal length at 60 centimeters, which is actually the better working distance for all of us. And if you see from distance to intermediate and near and a lens plane, it gives a continuous range of vision right from the 40 centimeter to a 80 centimeters in other areas. Here is 60 centimeters. So 40 to 60 centimeter, we get a continuous range of vision, which you can appreciate in this defocus curve. Right from a 60 to 40, it has a nice defocus curve, which gives a better vision. Compared to other lenses, this is a hydrophobic lens, which has the diffractive refractive design. And most importantly, it gives a 88% light transmissions and continuous range of vision from a 40 to 60 centimeters. And if you look into this, other area of concern for all multifocal lenses is the pupil dependence. This lens doesn't depend on pupillary size, which is a very important aspect for looking into a decreasing glare and halo for these patients. Trifocal lenses, in fact, any other lenses which you put in an eye would require a very precise biometry, which is more important for multifocal and trifocal lenses. Optical biometry would give you a better assessment for these cases. In that also, it is very important to look for astigmatism, because astigmatism is the one where patient may not be happy after surgery, because the significance of a residual astigmatism is much more important for trifocal lenses. So not only the anterior astigmatism, the posterior corneal astigmatism has to be looked into, because that might change the requirement of a toric lenses from from T3 to T4 in this particular case, which will give a very appropriate post-op refraction for your patients. These are the outcomes of a various trifocal lenses. We know that intermediate vision will be best with panoptic lenses, because at 60 centimeter, if you look at 80 centimeter, Symphony might give you a better, or a Synergy might give you a better intermediate vision in these cases. But looking into our results, we compared Panoptic's lenses versus the Symphony lenses, which were available at that time, extended range of vision. And we looked for a visual acuity in these cases, quality of vision, and patient satisfaction, apart from the near vision in these cases. Surgery-wise, we all know for any surgery, perfection of rexis is important. If you have access to a femtosecond laser device, which will definitely give you a better centration of a rexis in relation to an intraocular lens also. And subsequently, you can have a better effective lens position for your cases, because that is what is important for all these cases. Very nice, clear posterior capsule, which is important to decrease the post-op fibrosis of posterior capsule. The lens should be centered well, not only in regards to the central, the clear zone of refraction for these refractive diffractive lens. Apart from that, the toric axis has to be implanted in a way where you have at least deviation from the axis of its orientation. So these are some important points which is important for these cases. As we discussed subsequently, it is important that lens should be placed in a nice manner. And whenever we talk about trifocal lenses, we look for uncorrected visual acuity for distance and near. It was better than the extended range of vision lenses. Almost 100% of patients achieved N6 for a near and N8 or better in all the groups. But it took intermediate vision, 90% of more patients got better than N8 in all these cases. Near stereo acuity, because whenever we talk about binocular assessment of these lenses, stereo acuity is a better way to judge, and near stereo acuity was better with panoptic lenses. Similarly, for distance also, it was as good as the monofocal lenses, but it was definitely better than our extended range of vision lenses in our series of cases. Same holds true for MTF and Snell's ratio, it was better. And the higher order aberration induction was definitely less with the panoptic design lenses. And these lenses were far better. In fact, 100% of patients had no difficulties with the near work. And the dependency of glass was 100% was patients were not requiring glasses with panoptic lenses.
Dr. Jeevan sir,
which is the lens should be chosen for a trifocal lenses? Visual acuity wise, distance wise, all lenses have equal performance. Intermediate range wise, if you look into those areas, panoptic lenses will be far better compared to other lenses. And if you look for a range of vision wise, it also does a similar as 40 to 60 centimeter, gives an extended depth of focus as compared to other lenses also. Quality of vision, definitely yes, better. Patient satisfaction is still better in these cases. So if I compare the newer generation trifocal lenses, it is evident with our results and the results published in the international literature. Panoptics has a definite edge over the conventional trifocal lenses. Thank you for your kind listening.
Thank you so much, sir, for that excellent talk. Now, can we have the talk by Dr. Thang Fong, rationale behind cleaning and sterilization of ophthalmic surgical instruments. Video.
Yeah, Dr. Thang graduated from in medicine from Vietnam, and he trained in nephrology and then moved to Australia for his studies in tropical diseases, and then completed his PhD from Japan. And presently he's working as the head of the Department of Infection Control in Chore Hospital in Vietnam, and also a visiting assistant professor in Japan. And he has various publications in reputed journals and presented at various international platforms. And he'll be speaking to a pre-recorded talk. Can we run the talk now?
Can we run the video, please?
My presentation is processing and quality surveillance of surgical instrument in the Cherry Hospital. The content of my presentation have the three parts. First, I mentioned about a CAD system in Cherry Hospital. And second, is instrument processing process. And finally, I talk about inequality surveillance process. First content, I would like to talk about CASSD system in Cherry Hospital. The CASSD belongs Department of Infection Control and having two units. We name CASD Zone C, having the 30 staff, and CASD Zone D, have 5 staff. The mission of the CASD is cleaning instrument, packing tool, and fabric sterilization, and tool sterilization, and storage and distribution equipment for every department in my hospital. Next, I would like to demonstrate instrument preprocessing process. Here, I show in the guideline the Vietnamese Ministry of Health to issue the August 2017 to introduce the how to preprocessing equipment process in Vietnam. In this slide show in the CASD device in my department, including automatic washing machine, steam machine. We have in the 7 steaming machine, and then 4 low temperature sterilizer is named in the plasma, including 1 Steras on here and 3 Steras 100 NX in 2 units. This slide shows that the design of CASD is one-way flow from dirty area to clean, sterile area. This slide demonstrates how management of equipment and reprocessing process, including a step. First, after instrument used in the surgical department, we deliver to shipping or deliver to CASD. In CASD, equipment will be reassembled and cleaning. After cleaning, the staff of CASD will check clean and the function of the equipment. After that, the staff will packing the equipment in the container or the nylon wrap. Next step, the on equipment in container will be sterile, and after sterile will stop in the stock area and delivery for the user.
Very long, huh?
This is the dirty area to receive the dirty equipment after uses. The staff of CASD will receive the dirty equipment from the AV department, especially the surgery department. The staff will be disassemble equipment and manual clean. Very be careful. This step very important to make sure on the dirty equipment will be removed. It's very important to increase the efficacy of the sterile in next step. This slide shows the automatic cleaning system in my CASD. The only equipment at the pre-cleaning will be cleaned by the system, automatic cleaning system. After cleaning, the staff in CASD will check the function, also cleaning of the instrument. and packing in container or in the nylon packing. Here the slide showing the staff check the function of the scissor. They check in the quality of the scissor and using oil and check the function of the scissor and by cutting in the nylon. This slide shows the standard packing. The left photo show in the it's not good in the packing, but the right photo show in the good condition of the packing. After packing, on the instrument will be sterilized as following two protocol. In the left slide show in the heat resistant instrument protocol and Russia to serve for open surgical instrument such as glass, silicone, and so on. We name in the high temperature sterilized. In the right the slide in the show the non-heat resistant instrument that serve for microsurgery, endoscope, and plastic surgery. We name in the sterilized. It's a photo show in the heat resistant instrument such as in the abdominal surgery, thoracic surgery, and so on. This slide shows the non-heat resistant instrument, including vascular microsurgery, neuro microsurgery, ophthalm microsurgery, ENT microsurgery, plastic microsurgery, orthopedic microsurgery. This slide shows in the endoscope set such as abdomen endoscope container or thoracic endoscope container. This is the plastic ophthalm surgery set, which are sterilized by sterile, it means low temperature sterilized. Because this is the micro surgery equipment, so we use the low temperature, it means sterile or plasma technical to sterilize for this instrument. Here in the notice, very important for post-operative infections, endophthalmitis, and toxic anterior segment syndrome. These diseases are rare but can cause severe cases. Therefore, we need to be sure strict follow-up protocol of reprocessing instrument. Next, I would like to show the quality surveillance process of my CSFD in Cherry Hospital. We have 5 steps to check the quality control. First step, we check the cleaning quality. Next, we check the body test. And third, we check temperature test. And fourth, we check chemical test. And finally, we check the biological test. This slide shows how we evaluate the clean surface instrument. Every day after cleaning of instrument, we need to check in the surface of the equipment clean or not. We're using A3 detection. After that, we before every day we use the sterilizer. We have to check body test on the steam or machine. If the body test is okay, we can use the sterilizer for sterilize on instrument. However, if the body test fails, we have to check the machine again In here, the result of body test. In the left photo show in the body test is passed. It means the lines of the body test is very clear. However, the right side of the photo show in the body test failed. You can see in the some area in the body test, it is not clear. It means the machine has problem. We need to repair. In addition, we also use the compliance body with early warning. This test to early detection of the some problem or some broken of the machine. We can see here the upper photo of the early complete body test is the black dots. It's very clear. It means the machine is very good condition. However, the lower body test in the second to fourth in the body, the dot, black dots is not clear. So it means the machine have some problem, and we need to check and repair before we use for the sterilization. After we check the body test, we also use the chemical indicator. Is the name exposure control test. You can see the photo in the right side in the temperature tab. It means the color will change in the when machine reach 90 to 100 degrees Celsius. After that, we also use the chemical indicator level 4 or level 5 to check the package control. We have the two level. For example, level 5, we have the 2 parameter indicator, including temperature and time. However, in level 5, we have 3 parameter indicator, including time, temperature, and pressure. The result of the class 5 chemical indicator, you can see here in the left slide show the before steaming. It means we can see in the white area, and white area divide to two parts in the reject area and accept area. After sterilization, the result have in the two results. For example, if the chemical indicator show fail, it means the plug of the test in only reject area. And if results show pass, it means the chemical indicator plug will move to accept area. We can see here, it means the result sterilization of this process is okay. And finally, we also use in the biological indicator. This slide shows the development of biological indicator from the 1950. We need to spend 5 days, 7 days to get the result of the biological test. However, with the developing of the technology, now we just need 50 minutes to get result of the biological test. How we use the biological indicator? First, we have to prepare the biological indicator. This slide shows first we have to check in the catalog number and expiry date of the biological test, and we check in the rest in the upper of the tube. After that, we record the cycle number and the day on the label of biological indicator. After cycle completion, we have to check in the prince parameter and chemical indicator. We can see here We remove the BI from the sterols, and we check the color on the leaf, and we press the leaf firm down and squeeze the inner environment twig and hold BI in the upright position after squeezing. Why we need to use the control twig? Because the control group is the unsterile twig containing viable microorganisms, and for comparison with the test the BI, take the control twig in the same box and with the same parcel number as the test twig and the same operation at the twig. And next step, we read the result of the process of the BI monitoring. We place the test of BI in incubator within 5 minutes of the complete the cycle. Before we put the BI in the incubator, we have to turn on the incubator at temperature 55 to 60 degrees Celsius, and we put on the control and the BI test in the incubator, and we follow up in 5 minutes. The record time it takes to place BI incubator. We can see here for the test BI, if the good result is mean in the test BI in the still in the red color and pink in the twig. This means in the negative. This means on the viable microorganism and spore will die. But for the control twig, we can see the viable microorganism still alive. This means the color will be changed in the yellow. Let me summarize my presentation. First, we have to complete the central serialization unit design. Second, we have to make the standardization of surgical instrument reprocessing procedure. And the third, we should be standardized the quality surveillance process from receiving to distribution for all departments in a hospital. And finally, we need to use effective and safe surgical instrument to prevent on the infection diseases, especially for surgical site infection for all the operation cases. Thank you very much for your attention.
With this, we come to the end of this session. I'd like to thank all the chairpersons and all our guest speakers, and have a great evening. Thank you.
Thank you.
Once again, I'd like to thank everybody for joining us for this virtual event. Thank you all the speakers, chairperson, and panelists. Thank you so much for being on with us. Thank you.